So, welcome to second part of pharmacology, the endgame series. So, in this we'll be basically going through the rest of the pharmacology. So, we have already completed general pharmacology and we are here into 12th topic, that is anticholinergics. So, basically you should know what is cholinergic effect, that is what happens when body is under parasympathetic innervation and what happens when the sympathetic innervation is active. Sympathetic means wherever there is fight or flight, that response is sympathetic. Wherever there is rest and digest, that is parasympathetic. So whatever blocks this parasympathetic are called as anticholinergic. So their specific target is the M receptors, as you can see here. These M receptors or muscarinic receptors are the target of this anticholinergic drugs. Now because of M effect, what will happen is whatever is supposed to happen during rest and digestion doesn't happen. For example, you see the pupils are supposed to be constricted, focused when there is flight or fight. But here what happens in parasympathetic, we are concerned about pupillary. Yes, very good. Yes, we are concerned about pupillary. Sorry, in sympathetic, what happens is there is pupillary dilatation because you want more light to enter. Okay, you want to focus, you want more light to enter. Whereas in parasympathetic, what happens? Meiosis happens. But here in anticholinergic is against parasympathetic. So what happens? Pupillary dilatation, which is known as mydriasis. Okay, so mydriasis is a feature of anticholinergic. Similarly, secretions is a function of parasympathetic. Okay, oral secretions, lacrimal secretions. So what happens to this secretion? That secretion decreases by giving anticholinergic. So there is dry mouth. Okay, dry eyes. Similarly, parasympathetic function is to decrease heart rate. Okay, that is sympathetic function is to increase heart rate. So what happens in anticholinergic? Similar to sympathetic effect, it will cause tachycardia. Okay, so other systemic side effects you see, like I told, mydriasis, that is pupillary dilatation. What happens to ciliary muscles of the eyes, that is the lens? So what happens is here, that causes relaxation. Okay, so in parasympathetic, in anticholinergics, we get what is known as cycloplegia, that is we get relaxation of these ciliary muscles, and these are used for cycloplegics for pupillary dilatation. Okay, next what happens to GIT? GIT motility will decrease because we know that parasympathetic is rest and digestion, so there it increased, but here it will decrease when anticholinergics are given. Similarly, this is used for antispasmodic effect also. Okay, anticholinergics. Similarly, respiration, what happens? There is bronchodilation. Okay, because as you can see in some of this, the alpha receptors, the beta receptors which are present in the lungs for sympathetic, they also cause bronchodilation. But what happens in parasympathetic? They cause bronchoconstriction. So in anticholinergic, what happens? It causes bronchodilation. Similarly, heart, it causes tachycardia. Secretions decrease, so dry mouth, and there is decreased sweating. So all the features are similar to almost that of sympathetic, except one thing, that is sweating. Sweating is decreased in a parasympathetic inhibition, that is in anticholinergic, sweating is decreased. Okay, so that is the reason why we have this red as hair. Okay, you remember? No, red as hair, hot as hair, sorry. So why that happens is because there is no sweating, there is no heat production, there is no expulsion of heat. Okay, now what are the clinical uses of anticholinergics? This yes thing. Okay, yes for seasickness. Okay, this scopolamine. Okay, that is used for motion sickness. Okay, motion sickness, what we use? Scopolamine. It comes as a patch. Benztropine is again an anticholinergic which is used in Parkinson's tremors. Okay, you can see here benztropine. Next is ipratropium and triotropium. Ipratropium and triotropium is used for COPD management. Okay, it is also used in asthma management because it causes bronchodilation. Similarly, atropine is used in the case of bradycardia, or when there is AV block, because you know that atropine causes tachycardia. Okay, it causes tachycardia. So that's why I use atropine in AV block and bradycardia. And glycopyrrolate, it is a very unique anticholinergic which is used to decrease secretions. You know that parasympathetic innervation increases secretion, but anticholinergics will decrease secretions. Okay, so it is used as anesthesia pre-medication. Okay, now why during anesthesia pre-medication? That is because when you give anesthesia, patient won't be able to clear his secretions from the throat, okay, from the oral cavity. So at that time you want secretions to decrease. Okay, so how do you remember mnemonics of anticholinergic? One is dry, blind, hot, and mad. Okay, so these four things. What is dry? Dry is decreased secretion. Blind is cycloplegia and mydriasis. Hot is increased temperature because of decreased sweating, and mad is because of delirium. Okay, so this anticholinergic, whichever passes blood-brain barrier, they causes delirium. Okay, next, scopolamine causes what? Seasickness. Okay, so scopolamine is used in seasickness. There is one more drug which is used in seasickness, that is known as meclizine. Okay, meclizine. Now glycopyrrolate, there is no blood-brain crossing, so that is very good. That's why it doesn't cause delirium. Ipratropium, I for iPuff. Okay, that is you can just remember this as a puffy fish. Okay, puff fish which is there. Okay, so in asthma it is used. Okay, and also in COPD. So some things which you should be careful, especially for INICET. That is what happens when cycloplegia is affected. No, like you see here, the ciliary muscles are relaxed. So what happens is when there is angle closure glaucoma, no, the glaucoma, that angle is there, no, that is anterior chamber angle, that gets more constricted, and hence it can precipitate angle closure glaucoma. So this one thing, anticholinergics are contraindicated in angle closure glaucoma. Similarly, what happens in BPH? What happens in parasympathetic? See, let's say sympathetic, what happens? Okay, when a lion is chasing you, okay, that means you are running. That means you don't want to urinate there. No, like it is not like you are resting and you are urinating. You shouldn't have your urine should be controlled. So that same effect is happening in anticholinergic also. That is your urinary this muscles, no, that is sphincter muscles gets contracted and your detrusor gets relaxed. So what will happen is when you give in BPH, already there is urinary retention. Okay, symptoms of urinary retention. Now this one will actually worsen. Okay, next in infant there is risk of hyperthermia, that is because of decreased sweating. Next in elderly, delirium can occur and falls also can occur. Falls is because of mydriasis, because of cycloplegia effect, and delirium is because of atropine mainly. Okay, now physiostigmine is the antidote. Physiostigmine is the antidote because what is physiostigmine? Physiostigmine is nothing but it is cholinergic agent. Okay, it is cholinergic. Okay, so cholinergic agent physiostigmine is the antidote for parasympathetic anticholinergic poisoning. Okay, and then we have atropine which doesn't cross blood-brain barrier, and when there is dry mouth in anticholinergic use, that causes increased risk of dental caries because your secretions are not there, no? So increased chances of dental caries are there. Okay, so we'll go through the questions. All these are very, very, very important things. Okay, I urge you to go through it in detail. I can't explain you everything in this video lecture. Okay, so motion sickness prophylaxis, what we give scopolamine. But if you have in motion sickness scopolamine, if it is seasickness, then remember we give meclizine. Okay, meclizine. Next, Parkinson tremor control, yes, very good, benchtropine. Okay, benchtropine we give. Organophosphate bradycardia, which we give, remember whenever there is OP poisoning, there are only two drugs. One is atropine and the second one is pralidoxim. So second drug is pralidoxim. Okay, so most of the things I have discussed, whatever was there in the image, extra things are there, you just highlight it. Okay, high delirium risk is with atropine. Okay, so I remember during our internship postings, whenever we give atropine for OP poisoning, they used to have a lot of delirium and all. Okay, what is used perioperatively to decrease secretion? It is glycopyrrolate. So these are the ones which I have underlined. No? These are the ones which are commonly used in clinical practice. That's why I have underlined them. Okay, dash used in only severe central anticholinergic toxicity with ECG monitoring. Yes, very good. It is physiostigmine. Physiostigmine is the antidote. Okay. Yes. Now we'll go to one important differential diagnosis of atropine toxicity, that is anticholinergic overdose, that is amitriptyline or TCA. So what is amitriptyline? Amitriptyline is nothing but it is an antipsychotic. Okay, it's an antipsychotic and it comes under the class of tricyclic antidepressants. Now why this amitriptyline or TCA are closely related to atropine toxicity? That is because this amitriptyline and this TCS, they have some features of anticholinergic. Okay, they also have some anticholinergic features, so they also present similar to atropine, but both of their treatment is very different. That's why we'll be seeing now what are the changes and how you diagnose and what are the different lines of management for both of this, because this is a standard NEET PG question, and you will note that say both of these options will be definitely there. Okay, if you are given atropine toxicity, and one of the options will be amitriptyline and any other TC. Okay, tricyclic antidepressants. Okay, so we'll go through this right now. Whenever in your NEET PG, if there are two options regarding atropine toxicity, that is anticholinergic toxicity, okay, and when the options are whether to distinguish between atropine and TCA such as amitriptyline, then your answer should be straightforward. Okay, you shouldn't have any doubt. That's why I'm clearing this concept here and there itself. Okay, so first is atropine or anticholinergic toxicity. What happens is the blockade happens at only muscarinic receptors, nowhere else. It is from muscarinic 1 to muscarinic 5 receptors, nowhere else anything happens. But in case of amitriptyline or in case of TCA overdose, you should know that in addition to muscarinic receptor, it also inhibits alpha-1 receptor, that is sympathetic. It also inhibits H1 histamine receptor. It also inhibits, what is more important to us, the sodium channels, and these sodium channels are responsible for maintaining membrane polarization in cardiac cells. Okay, so this can actually cause arrhythmias. Okay, so arrhythmias are a very important component of TCA toxicity and not atropine toxicity. Next, very important clinical finding, not clinical, actually it is investigative finding, which helps you to differentiate is ECG, because in atropine toxicity, I told you what happens. The sympathetic effect, that is tachycardia, happens. Nothing happens to the QRS complex. They are normal QRS complex. They may be narrow QRS complex because of tachycardia. But what happens in TCA toxicity? It will cause a wide QRS complex. This wide QRS complex is the hallmark to differentiate between atropine and amitriptyline toxicity. So remember, wide QRS complexes, which can lead to ventricular arrhythmia, which can lead to hypotension. Okay, so this is the hallmark of TCA toxicity. So the moment you get ECG showing QRS widening in TCA anticholinergic toxicity, always remember TCA is the answer. Second is the seizures. Seizures is more towards TCA toxicity than atropine toxicity. When atropine toxicity, you don't get seizures usually. Okay, and then the common things are same. Okay, that is the peripheral sign, that is hot as hair, dry as bone, mad as hatter, and blind as bat. This anticholinergic syndrome is, that is common for both of these. Now, why is this so important? Is because treatment here is, in case of atropine toxicity, is physiostigmine. Okay, here it is physiostigmine. Now, what happens is, if you give physiostigmine in TCA toxicity, what happens if you give physiostigmine in TCA toxicity? It can cause asystole. It can cause asystole. It can cause to immediate cardiac arrest. So that's why to give this treatment, that is physiostigmine, you should be very sure that it is not TCA toxicity. Got my point? Here the treatment of choice becomes sodium bicarbonate. Okay, sodium bicarbonate is the treatment of choice, but if the patient goes into torsades de pointes, that is because of sodium channel inhibition it happens. Okay, then you will have to give magnesium sulfate, which is the drug of choice. Okay, so I think I have explained everything. What is QRS widening? QRS widening means QRS interval is more than 100 milliseconds. Okay, so we'll just quickly see the questions. What is the single cardiac finding which distinguishes is QRS widening? So what is QRS widening? More than 100 milliseconds QRS interval is called QRS widening. So what is the CNS effect? CNS effect for is seizure in case of TCA and delirium in case of both. Both atropine and amitriptyline causes delirium, but seizure is predominantly caused by TCA. Now, peripheral signs are both, it is same, both share the anticholinergic triad, that is hot as air, dry as bone, and mad as hatter, and blind as a bat. Now, what is the antidote for TCA toxicity? That is sodium bicarbonate. Okay, sodium bicarbonate is the antidote of choice. Magnesium sulfate is given if there is torsades de pointes. What is contraindicated in TCA toxicity? Physiostigmine is contraindicated. Okay, physiostigmine is contraindicated. So we'll go to next topic, very important, that is beta blockers. Yes, so we'll go to beta blockers now. Basically, beta blockers act on two receptors, that is alpha type of receptors and beta type of receptors. Okay. Now this beta 1 receptor, you should remember that beta 1 receptor is present in heart. Okay. Beta 2 is present in bronchial smooth muscles. Okay. So this is present in the bronchioles. Okay. Alpha receptors present in the blood vessels. Okay. So that leads to vasoconstriction. So what you need to know is, one is cardioprotection. Okay, sorry, we'll go before that. This is the beta blocker drug. Okay, it sits on the beta receptor present on the cells. It decreases CAMP, acts via CAMP. Now what it does is, it decreases heart rate and contractility. Why? Because sympathetic system increases heart rate. Beta blockers block that effect, so that decreases heart rate and decreases contractility, and hence it decreases BP. That's why beta blockers are also one of the first line in antihypertensives. Okay, so what it will do is, because it is decreasing heart rate, it is decreasing myocardial oxygen demand. Okay, so this is the basic thing that you should remember. Now, how are beta blockers classified? See, beta blockers are classified into three types. One is non-selective, that is they act both on alpha and beta. Second generation, that is beta 1 selective, means they act only on the heart. And third one is vasodilator, that is third generation, which have alpha plus beta activity. Okay, and their mechanisms are slightly different. So in first generation, which are non-selective, it will act on the heart also. And what is beta receptor supposed to do? It is supposed to do bronchodilation. But what will beta blockers do? That will cause bronchoconstriction, correct? So these first generation non-selective, they will cause heart rate to decrease, it will cause decreased myocontractility. Yes, it is useful, but at the same time it will worsen one significant disease, that is asthma. Okay, so they're contraindicated in asthma. So which are the examples? We have propranolol, nadolol and timolol. Out of this timolol, no, it is a topical it is a topical beta blocker that is used in glaucoma. So timolol is used in glaucoma. Okay, now coming to second generation, which are very specific for cardiac, beta 1 only. Okay, they don't have effect on the lungs and other tissues. So these are metoprolol, atenolol and esmolol. In this, if you see, this esmolol is very unique because it is also present as a beta blocker under anti-arrhythmic drugs. Okay, under anti-arrhythmic drugs you will find esmolol also. And second thing is, esmolol is the shortest acting beta blocker. The effect lasts like 5 to 10 minutes. Within that, the effect is also done. The whole drug gets washed out within that. Okay, so this is very short acting beta blocker. Okay, next we have third generation, which act via different mechanisms. In these two things, carvedilol and labetalol, they are alpha plus beta. Okay, they are both selective, and nebivolol acts via release of nitric oxide. Okay, so these three very important things regarding mechanism of actions are very frequently asked questions. Okay, now what does beta blockers do? Beta blockers decrease heart rate, they decrease myocardial contractility, and they give cardiac protection. How? In the form of decreasing heart rate, that decreases myocardial oxygen consumption also, and also it causes decreased release of renin. Okay, so these three mechanisms lead to cardio protection. Now, what are the major clinical indications for using beta blocker? One is hypertension, you know that it decreases BP. Second is in case of angina, beta blockers. And third is in MI, post MI, there will be mortality benefit. This is with help of two drugs. One is M and C. That is, M is for metoprolol and C is for, just a minute, C is for carvedilol. Okay, so M is for metoprolol and C is for carvedilol. Okay, carvedilol. Now, for heart failure with reduced ejection fraction, okay, we use these three drugs. What is heart failure with reduced ejection fraction? It is nothing but systolic heart failure. Okay, heart failure with reduced ejection fraction is systolic heart failure. In systolic heart failure, we'll use cardioselective. I said no, carvedilol, metoprolol, bisoprolol. Okay, for glaucoma we use timolol and thyrotoxicosis, and in case of tremors, okay, we use something that is known as propranolol. Okay, propranolol is the beta blocker of choice for thyrotoxicosis and tremors. Okay, now what are the adverse effects? I told you one is bronchospasm. It is more in case of non-selective beta blockers, and this is a very repeated question. Second is it can cause sexual dysfunction, erectile dysfunction. Third is it will mask hypoglycemia. Now what happens is whenever there is hypoglycemia, our sympathetic system kicks in and it will try to manifest some symptoms like sweating, then there will be like anxiety, there will be panic, there will be tachycardia. Now all these symptoms are masked by what? It is masked by beta blockers because they block sympathetic nervous symptoms. Okay, and propranolol, high propranolol can also cause CNS effects such as depression and fatigue. Okay, so what are the points where you will have to avoid? One is avoid in a variant of angina that is known as Prinzmetal angina. Okay, so there is something called as Prinzmetal angina where the angina that is caused is because of vasoconstriction of the vasospasm of the coronary blood vessels. Okay, so what will happen is beta blockers, you know, they will block beta receptors and they'll activate alpha receptors. Okay, so what happens is when these beta blockers are blocked, no, like beta 2 actually causes vasodilation. Okay, alpha receptors cause vasoconstriction. So what will happen is this action is opposed, so there is no vasodilation. Along with that, there is unopposed alpha action also, especially when you give non-selective when you give selective beta blockers. Okay, so that's why in Prinzmetal angina we avoid beta blockers. Second is sudden abrupt withdrawal will cause rebound tachycardia, and that can cause rebound hypertension also. Third thing is non-selective beta blockers are contraindicated in bronchospasm. Okay, now for performance anxiety and tremors we give propranolol. Ultra short acting is esmolol. T half is 9 minutes. And in pregnancy, the safest beta blocker is labetalol. Okay, so in any hypertensive urgency or in case of pregnancy where patient suppose comes with preeclampsia or maybe pregnancy induced hypertension, you need to lower BP suddenly, you will give labetalol because labetalol is alpha plus beta blocking. It has both actions. So I think these things we can go through. There is something known as ISA. ISA means intrinsic sympathomimetic activity, which means there are some beta blockers which which have beta agonist activity along with beta blocking action. Okay, so they are beta blockers, but along with that they have partial beta agonist activity. So example of this is, one is bisoprolol and another is esabolol. Okay, sorry, it is not bisoprolol, sorry, it is pindolol. Okay, pindolol and esabutalol. Okay, so these two drugs, they have some intrinsic beta agonist activity, because of which they are not good in MI. Okay, post MI, these two drugs are not of any use because of their partial agonist activity. Nitric oxide release is related to nebivolol. Remember, N for N. Okay, so heart rate ejection, reduced heart ejection fraction, heart failure mortality benefit ratio is obtained by CMB. CMB means carvedilol, metoprolol and bisoprolol. Okay, these three things you will have to remember. Now we'll go to the question section. Which are the first generation non-selective beta blockers? Yes, very good. One is propranolol, that is your prototype drug. Second is yes, very good. Yes, nadolol. And third is timolol. Timolol is the glaucoma drug. Okay. Next, which are the beta 1 selective? Metoprolol. Yes, very good. Esmolol. And third is, yes, very good, which is that atenolol. Okay. Next, which are the third generation alpha plus beta blockers? Yes, first one is carvedilol, second one is labetalol, and third is nebivolol. Okay. So there shouldn't be any doubt regarding these 9 drugs. Okay. Next, which has anti-arrhythmic property used as membrane stabilization? Use propranolol. Okay, propranolol is used for membrane stabilization and as anti-arrhythmic. Now, what releases nitric oxide and causes vasodilation? Nebivolol is the answer. Which is the shortest ultra-acting? Yes, very good. Esmolol. Okay. Which is the topical antibiotics? Remember, topical T for T, timolol for T, topical. Okay. Next, dash beta blockers plus asthma is bronchospasm. First generation, that is non-selective. First generation, not non-selective. Okay. Drug which decreases mortality post MI is 2 drugs as told, carvedilol and metoprolol. Okay, and one more in reduced ejection fraction heart failure, which one we use? That is bisoprolol. Okay, beta blockers mask adrenergic symptoms, but not, except which there is one symptom which they don't mask, that is sweating. Okay, this is in case of hypoglycemia. Okay, next, dash is preferred in pregnancy induced hypertension. Yes, very good. Labetalol, nothing else. Okay, only labetalol. And what is used for performance anxiety and tremor? Yes, we use propranolol. See, all these are drug of choice questions. Okay, so that these will be definitely be asked in your exam. So this whole image is a very high yield topic. That's why I'm dedicating so much time in explaining these topics. So next we'll go to beta agonist, that is adrenaline and epinephrine. Next we are going into beta agonist. Okay, so in beta agonist we have one important prototype drug, that is adrenaline. Remember, in your exam 2 options will be, one will be noradrenaline and second will be adrenaline always, and you'll miss one of these two if you don't understand the concept well. So basically sympathetic system is for flight or fight response, I told you. So what happens is, there are endogenous catecholamines, ADR or and nor-ADR, which are released. So this synthesis is from tyrosine. So this is also a MCQ. Which amino acid is the precursor for adrenaline and noradrenaline? It is tyrosine. Now this causes dopa. Okay, dopa leads to dopamine, and that leads to noradrenaline. In adrenaline medulla, this noradrenaline gets converted into adrenaline. So what is the difference between noradrenaline and adrenaline? Basically, nor-ADR is secreted by the neurons of sympathetic nervous system. ADR is secreted by the hormonal pathway. So there are some important things that you need to know about ADR and these receptors. I told you already that there are alpha receptors, there are beta receptors, and in alpha there is alpha 1, alpha 2, and in beta there is beta 1, beta 2, beta 3. These are the sympathetic receptors. Okay, that is sympathetic system receptors. Okay, adrenaline receptors. Now out of this alpha 1, alpha 2, beta 1, beta 2, beta 3, ADR acts on alpha 1, alpha 2, this is for ADR. Okay, alpha 1, alpha 2, beta 1 and beta 2. Okay, but nor-ADR doesn't act on beta 2, and this is a very important thing that is to be noted, because beta 2 is present in skeletal muscles. Okay, beta 2 is present in skeletal muscles, and this causes vasodilation. Okay, so if something ADR is non-ADR is not acting on skeletal muscles, it is not causing vasodilation, so it has more of vasoconstriction effect. Okay, this is one thing you need to remember. Now what will happen because of sympathetic activity? Heart rate will increase, contractility will increase, and there will be increased cardiac output. This effect is mediated by beta 1. Now there is something called as biphasic BP curve. What does it mean? Initially at low doses, when you give ADR, what will happen is it will act on beta 2 receptor, okay, because of which there is vasodilation. Okay, there is drop in BP, but at higher doses it leads to beta 1 action. So then it leads to alpha action. Okay, it causes vasoconstriction, and that's why there is increase in the blood pressure because of vasoconstriction. Okay, so this is known as biphasic BP curve of ADR. What happens in respiratory? There is beta 2 activity of ADR, hence it causes bronchodilation. What happens in vascular? I told you, beta 2 causes skeletal vasodilation, skeletal blood vessels, and in skin it causes vasoconstriction via alpha 1 action. So there is something known as redistribution of blood. Okay, and next, what happens under beta 3? Beta 3 receptor actually stimulates increased glycogenolysis, increased lipolysis, increased glucose and all. Okay, so basically body is preparing you to fight against some external stimulus. Okay, now in the ocular, what happens? Now light should enter as much as possible, so that you can see everything, so your eyes become big. Okay, so it causes mydriasis without cycloplegia. Now if you remember, when we were talking about anticholinergic drugs, that time what was happening was there was mydriasis, that is there was anticholinergic effect, that is cholinergic effect is to constrict pupils, anticholinergic is to dilate, but along with that there was something known as cycloplegia. Cycloplegia was paralysis of this ciliary muscles of the eye, which causes accommodation reflex. Okay, now what is happening in sympathetic nervous system, that is in case of ADR, adrenaline, is that mydriasis occurs, but there is no cycloplegia. This is an important MCQ point. Okay, next, what happens under renal? Because of this alpha dose, renin will decrease initially, but when there is beta 1 dose, there will be increased renin. So what we are concerned about is increased renin. Okay, now what are some of the useful things that we should know for exams? One is, at low dose there will be beta mediated vasodilation, and at high dose there will be alpha mediated vasoconstriction. Second is, in IM route we are always giving ADR. ADR is the drug of choice for anaphylaxis, and this is not given through IV route. Remember, here many of you commit mistake. It is always given through IM route. Okay, it is not given through IV route, it is given through IM route. And what is the dose? Dose is 1:1000. Now what is 1:1000? When you take ADR ampule, okay, that is vial, okay, in that vial the concentration that is there, that is 1:1000. So this is given via IM route. But the same drug, same thing, whenever it is given through IV, we give at 1:10,000 concentration. Okay, 1:10,000 concentration. And how do you do that? You dilute this same drug in 10 ml of distilled water. Okay, so that is how you create increased diluted concentration. Okay, now anaphylaxis drug of choice is not noradrenaline, it is ADR, adrenaline, via intramuscular route. Next, it is the IV drug of choice for cardiac arrest. Now here the dose is 1:10,000. Okay, because for cardiac arrest we want immediate effect. Okay, and then for local anesthesia, whenever we give local anesthesia, we give ADR, because ADR will cause vasoconstriction and it will allow the drug to stay in that area, that is lignocaine, for longer time, so it will prolong local anesthesia. And there is something very, very important known as adrenaline reversal. This is also known as vasomotor reversal of Dale. Okay, vasomotor reversal of Dale. Now what is this meaning of this, and why is it so important? Why is it repeatedly asked? See, I told you that whenever there is alpha and beta action, what does alpha do? Alpha will cause vasoconstriction. Okay, so it will cause vasoconstriction. What will beta cause? Beta will cause vasodilation. So whenever you are giving ADR, what will happen? It will cause vasoconstriction, so vessel will become small, correct? Now what happens when you give alpha blocker also? So phentolamine is an alpha blocker. Okay, so when you give phentolamine, the vasoconstriction is inhibited, so there is no vasoconstriction, but ADR will also act on beta receptor. Here it causes vasodilation, so instead of vasoconstriction there is paradoxical vasodilation. ADR shouldn't cause vasodilation, but when it is given with alpha blocker, it causes vasodilation. This is known as reversal of ADR effect, or it is known as vasomotor reversal of Dale. Okay, there shouldn't be any confusion. It's a repeated MCQ. Now, what mistakes do you do? One is what is that? This in severe hypertension, we don't give beta agonist and ADR because anyways it will cause hypertension. Second is it is not used for angle closure glaucoma. Again, it will reduce the like that angle, okay, anterior chamber angle. Next is do not inject into terminal parts where there is limited blood supply. There is only one artery going into that. You shouldn't give ADR block. There will give only lignocaine, okay, without ADR. Where are the examples? Like terminal arteries, like in the digits, in the fingers, okay, because after that there is no anastomosis. Similarly in the penis, in the nose, in the ear, so all these areas can lead to necrosis if you give lignocaine along with the ADR. This is an important point. Next, this I have already discussed. This also I have already discussed. Whenever you give ADR, you will have to monitor for potassium. That is because ADR via beta 2 receptor will cause transcellular shift of potassium. That is, it will cause potassium from the blood vessel to go into the cell. As a result, in blood vessels in the blood, potassium will decrease. So a cause for hypokalemia is beta agonist, that is ADR. So you have to monitor potassium levels. So all these things we'll discuss during the question answer session. So we'll quickly go through the questions. Okay, what happens at low dose? Low dose ADR, yes, vasodilation occurs via mediation of beta receptors, especially beta 2. At high dose, what happens? There is vasoconstriction via alpha 1 receptors. Very good. Now respiratory beta 2, what does it cause? It causes bronchodilation, okay, because ADR is beta agonist. In ocular, midrest is caused by alpha 1 mediated receptor mediated activity. Next, what is used topically to prolong anesthesia? We use adrenaline. Okay, adrenaline is used along with the lignocaine to prolong anesthesia. What is the drug of choice for anaphylactic shock? IM ADR, adrenaline. Okay, not noradrenaline. Now, if reversal with phentolamine, what we call it as? We call it as vasomotor reversal of Dale. Okay, vasomotor reversal of Dale. Next, dash is given mid anterolateral thigh, that is 0.3 to 0.5 mg of what? 1:1000 ADR. Okay, 1:1000 is the concentration. Monitor what? Monitor potassium, because beta agonist, that is ADR, can cause transcellular shift of potassium into the cells leading to hypokalemia. Next, we will go gradually to CVS. So we'll have nitrates followed by antihypertensives and antiarrhythmics. Okay. Okay, going on to CVS of pharmacology. So we'll start with the nitrates. Okay, so these nitrates, they act through the mechanism of nitric oxide generation. So these nitrate drugs, there are mainly two types. One is glycerol trinitrate. We also call it as nitrotriglycerine, okay, GTN or NTG. And we have isosorbide dinitrate, okay. So these two are the formulations which is available. Mechanism of action is simple. That is, it increases CGMP. Remember, in most of the cases it is CAMP, but in case of nitrates it is CGMP. You can see now here CGMP, okay. So this guanyl cyclase is present in the smooth muscles, okay. So this CGMP activates guanyl cyclase, and that causes along with this nitric oxide acts on this CGMP, causes activation of CGMP, which finally leads to smooth muscle relaxation. So what it causes is vasodilation basically. So nitrates means vasodilation. Among vasodilation, the important thing is venodilation. Okay, it leads to venous pooling. That's why it decreases the preload, the blood that comes into the heart. Okay, yeah, see here it decreases the preload, so it causes venodilation. Arterial dilation is minor effect, but we are majorly concerned about venodilation. What happens is when this venodilation, less blood comes into the heart. So in a failing heart, okay, the effect of the myocardial oxygen demand decreases, because now you have less load on the heart, less pressure to pump out, and it relieves also coronary spasm in case of Prinzmetal's angina. Okay, so what are the hemodynamic effects? See here, when there is a lot of blood coming into the heart, we need to decrease preload. Okay, so high left ventricular end diastolic pressure and wall stress is common, is dangerous in a failing heart. Okay, so what we do is we decrease the left ventricular ejection diastolic pressure, and we also decrease the wall stress on the ventricles. Okay, so that's why heart can pump better. So how is it used? It is used as sublingual. Very important. We discussed about sublingual part in routes of administration, topic number 4. Okay, so that's why it has rapid onset and it has acute onset also. It can also be used as transdermal patch for sustained effect, GTN. Okay, remember this. Oral tablet is used for prophylaxis, and you need 8 to 12 hours of nitrate free interval to avoid tolerance. So what is tolerance? So when you take this drug again and again, so the effect will decrease actually. So that is known as tachyphylaxis. Okay, So for this to prevent, you should give 8 to 12 hours of nitrate free interval. Okay. What are the adverse effects? So adverse effects are related to vasodilation only. So when there is vasodilation among the meningeal vessels and brain vessels, what will happen is it will cause headache. Flushing is also because of vasodilation. Now what happens is when there is vasodilation, what happens? There will be reflex tachycardia, okay, to compensate for the decreased cardiac output. So that's why we will have tachycardia in these patients, and it can also lead to severe hypotension if it is combined with the PDE5 inhibitor, that is sildenafil. So never combine nitrates along with sildenafil. Okay, so this will be your standard question on NEET PG during MCQ solving. Okay, now what are the other effects that you will see? So these are basically tolerance mechanism for nitrates. Okay, so what are the two mechanisms through which tolerance develops? So one is there are some sulfur groups, SH groups inside the cells which get depleted with repeated nitric oxide generation. Okay, so no SH groups are present for nitric oxide generation, and hence the drug can't act. Okay, so tolerance develop, you need higher doses. Second is neurohormonal counter regulation. That means that whenever nitrates cause vasodilation, it will decrease BP and it will increase renin-angiotensin activating mechanisms. Okay, so as a result of this BP is restored. Okay, so it appears that the effect of nitrates, that is vasodilation, is counteracted by this. Okay, so this counteracted effect is known as neurohormonal counter regulation. Okay, so these are the two mechanisms for which nitroglycerin or nitrates tolerance develops. Now what is Monday disease? This Monday disease is basically not with nitrate use, but there are factory owners who get exposed to some nitrates during their work. Okay, so what happens throughout the week, they will have this exposure to nitrates, so they will develop tolerance. And one day, that is on Sunday, they'll have holiday, they'll go home, and when there is re-exposure, that effect multiplies. So they'll have headache, they'll have flushing. Okay, so this is known as Monday disease. Also nitrates, one more important thing is it will increase collateral flow. Okay, so in coronary artery disease, what this nitrate do is wherever there is block, it will cause more collaterals to open up. Okay, so that's why it is also beneficial in cases of ischemic heart disease. Okay, so what are the contraindications? One important contraindication is the hypertrophic cardiomyopathy. Okay, because in HOCM, that is hypertrophic cardiomyopathy, what happens is already the output of the ventricles is narrowed. Okay, so when preload and afterload is also decreased because of nitrates, what will happen is the total circulating volume will decrease abruptly. Okay, so that's why it is very dangerous to give in HOCM. Okay, second is abrupt withdrawal of nitrates can also cause a rebound risk of angina. Okay, so this is also a risk. Third is with beta blocker, when you give this one, then reflex tachycardia chances are high. Okay, sorry, this was a mistake, sorry. The beta reflex tachycardia caused by nitrates. Okay, I told you that reflex tachycardia occurs. This reflex tachycardia is suppressed by beta blocker. Okay, so you know that I told you beta blockers decrease resting heart rate, and it also decreases myocardial oxygen demand. Okay, so as a result of which, when nitrates are combined with the beta blockers, it will give better anti-anginal effect. So nitrates will supplement the action of beta blockers. So what are the predicted questions? One is, what is the drug of choice for acute angina? It is acute angina, the drug of choice is sublingual nitrates. Okay, next, what is the mechanism behind action of nitrates? That is, it decreases preload via increasing cGMP and hence causing vasodilation, mainly venodilation. Third is, what are the after nitrate use, what are the problems that can arise? One is flushing, second is headache, and fourth is you should avoid sildenafil along with nitrates because of risk of severe hypertension and reflex tachycardia. Okay, so what is this preload? Preload means venodilation. Okay, so just to show that balloon shaped preload means it causes venodilation. Okay, so there is dilatation. Okay, and tolerance free interval for nitrate is 8 to 12 hours. Okay, after which you can like tolerance will decrease. Okay, so during this tolerance free period, there won't be any like tolerance developing. So that's why after this you will be giving nitrate again. Okay, so you should have 8 to 12 hours of nitrate free period so that tolerance doesn't develop. Okay, so let's go to the questions. Okay, first question is, tolerance dash develops with continuous use. We call it as tachyphylaxis. Okay, tachyphylaxis is the tolerance that develops with continuous nitrate use. What are the drug interaction? It is contraindicated with which inhibitors? PDE5 inhibitors, which is sildenafil. Dash disease in workers causes nitrate tolerance and headache. This is Monday disease. Okay, this is due to exposure to nitrates during their work. Okay, Nitric oxide activates DASH in smooth muscle. It activates guanyl cyclase, okay, guanyl cyclase, which increases CGMP, okay. DASH is due to meningeal vasodilation. What happens? Headache occurs due to meningeal vasodilation, okay. Next, drug of choice for acute angina is sublingual glycerol trinitrate or GTN or nitrates, okay. So I think I have explained everything, okay. So there's one more thing which I wanted to explain is this patch I told, transdermal patch, that is used at night to prevent tolerance, okay. So patch means there will be slow release of the drug, so tolerance doesn't develop altogether, okay, suddenly, okay. So next we'll be going through anti-arrhythmic drugs, and this is a very important topic. So basically there are total 4 classes of drugs, okay. So class 1, class 2, class 3 and class 4, okay. So class 1 is related to sodium channel, class 2 are beta blockers, class 3 are potassium channel openers, and class 4 are calcium channel blockers, okay. So you shouldn't confuse it. First means sodium, second is beta blockers, third is how to remember all this, I'll tell you the mnemonic, okay. So class 1, see, sodium comes under first in periodic table, it comes under first column, right, along with lithium, sodium, potassium, all this comes under first column, okay. So sodium is 1. Beta blocker, what is the meaning of beta? Beta means 2. You remember alpha numericals, alpha, beta, gamma, so beta means 2, so it is class 2. Class 4 is calcium. Now how do you remember class 4 is calcium? Whenever you write calcium, what do you see? You see it as 2 square, right? So 2 square is something raised to the power of 2, okay? So it is almost equal to 4, okay? And what is left? Potassium is left, so it is 3. Now how do you remember this? See, potassium, okay? You write this 3, no? So potassium, so K, okay? So it appears like a 3, okay? So potassium is class 3, okay? These are the things you need to do to remember, okay? So class 1 is sodium blocker, sodium channel blocker, class 2 is beta blocker, class 3 is potassium blocker, and class 4 it increases the APD. APD means action potential duration, okay? Action potential duration. And class 4 is nothing but calcium channel blocker, which acts on the AV node, okay? So in class 1, we have 3 different phases, okay? That is class 1A, 1B and 1,3, 3 different types of drugs. So what happens is sodium channel, sodium ATPase is a common, pump, okay? Common pump which is there in the cardiac conduction system, okay. So this is the normal cardiac cycle that happens, okay, the normal cardiac action potential generation. So this is phase 0, okay. So what happens is this drug block this sodium phase, that is the influx, okay, whatever is there, no, the influx comes, that is through sodium channels, okay. So these drugs block this phase of the so this is phase 0, okay. So phase 0 is nothing but the depolarization phase. These drugs block this depolarization phase, okay. So what about class 1A? 1A is moderate. Okay, so what this phase 1A does is it will cause blockade in the sodium channel, okay. This is fast depolarization, sodium channels, and this is for potassium, okay. So you should remember that in cardiac action potential generation, this is for sodium, okay. Briefly I'm telling you, okay, this is for calcium, this plateau phase, and this is for potassium, the repolarization phase, okay. So what 1A does is it will act on this sodium channel also, okay. It is a moderate sodium channel blocker, and along that, with that, it will also act on potassium channel. So it will block this one also, and it will prolong this one. So there is increased action potential generation duration, okay. Now the examples of this are quinidine, procainamide and diisopramide. So there is no separate mnemonic to remember this, but quinidine, QPD, okay, just like some Queensland Police Department, okay. So this QPD is for 1A, okay. Next is 1B, where there is a weak sodium channel. So this is weak, and it will shorten this repolarization duration also. So you will have a very small phase of cardiac cycle, okay, not cardiac cycle, cardiac action potential generation. And this is mainly seen in this ischemic tissues, okay, where there is ischemic tissue, like after MI. So that's why these drugs are also used in post-MI ventricular arrhythmia. So it specifically goes into those infarcted tissue, and it blocks conduction in those tissues, okay. So we have lidocaine and mexiletine, so LM, okay, lidocaine and mexiletine is for 1B. Now 1C is where it is strong sodium channel blocking also, and it has it has action on potassium also, okay. So overall the potassium and this one is not changed, okay. The cardiac conduction, the action potential remains the same, but it has strong sodium channel blocking effect, okay. So here we have F and P, that is flecainide and propafenone, and this is to be avoided in structural heart disease because That is because these drugs have very strong sodium block. Okay, so it can precipitate some other arrhythmias also. That's why in structural heart disease means where like valvular heart diseases. In post MI, there are some like post MI scar, or there could be some cardiomyopathies. Okay, so in this we'll be avoiding this because it has propensity to precipitate arrhythmia. Okay, so you should remember what are the categories. So if you see the graph of action, cardiac action potential, this is for sodium, this is for calcium, and this is for potassium. Okay, so class 1 acts on this sodium channels. So class 1A, I said what is the mnemonic? Queensland Police Department. Okay, so this acts on this sodium also. Okay, so it will block this moderate block, and also it will slowly prolong this potassium repolarization also. So we will have a broader cardiac action potential graph. Okay, now what happens in 1B we have two drugs, that is L and M, that is lidocaine and mexiletine. So what these do is these are weak sodium channel blockers, but they significantly decrease the total action potential duration. Okay, so action potential duration is decreased. What happens in 1C? 1C is F and P, that is flecainide and propafenone. Okay, so what it does, it is very strong sodium channel blocker, very strong. That's why we don't give in structural heart diseases, and it will keep the overall action potential duration will be the same because it doesn't affect the potassium channels. Okay, so these three things you should remember about class 1. Now, what about class 2? Class 2 are beta blockers. So their activity is basically on SA node and AV node. So it will delay the action potential. They'll act on these beta receptors, okay, which are there in the heart, which I told you already, beta 1 receptors, and their activation causes CAMP. Okay, so when decreased CAMP is there, decreased action potential will be there, and it will slowly conduct the impulses. So there will be slower regular heartbeat. So propranolol and metoprolol we have, which is the ultra short acting. We already discussed this. Esmolol is the ultra short acting. Yes, tell me which beta blocker class esmolol belongs to. Yes, is it non-selective class 1? Is it cardioselective class 2? Or is it class 3, which is newer variants? Yes, very good, very good. Yes, so esmolol is class 2. Okay, very good. Okay, cardioselective. Next, it is avoided in variant angina. This also we have discussed. Okay, so next, coming to class 3, which are basically calcium channel blockers. Okay, so what they do is in this graph, no, they will actually prolong this phase, that is potassium blocking phase. So it will increase action potential duration. It will increase the refractory period also. Okay, so you'll see this part is increased. Okay, so which are the examples for this? One is amiodarone, second is sotalol. Sotalol is a beta blocker. So your question will be, which is the only beta blocker which is a class 3 antiarrhythmic, and the answer is sotalol. Okay, next, third is dofetilide. So what is the okay, these both are side effects, that is torsades de pointes and long QT. Now why this occurs is because this action potential duration is increased. No, that's why we'll have long QTs also, and we'll have, because you see what is QT? QT is basically repolarization phase, which is prolonged. So those people who have long QT syndrome, in them these drugs are contraindicated. Also, second is it will also lead to QRS widening and causing torsades de pointes. What is the drug of choice for torsades de pointes? Yes, very good, magnesium sulfate. Out of this, the most important action is of this amiodarone. This amiodarone is used, it has all action, that is it has class 1 action, it has class 2, 3 and 4 actions also. Okay, and that's why if anyone asks you which is a drug that you can actually give for if you have a doubt whether you have to give class 1, 2 or 3 or 4, the safest would be amiodarone. So in most of the cases of arrhythmia, amiodarone will be the drug of choice. Okay, and class 4 is calcium channel blockers. So these block conduction at AV node. You remember, no, beta blocker is at SA node, and AV node will have calcium channel blockers. And not all calcium channel blockers. There are two types of calcium channel blockers, dihydropyridine and non-DHP. So here we'll be using dihydropyridine. There are two types, that is two drugs, verapamil and diltiazem. Okay, rest of them are non-DHP, like nifedipine, amlodipine, cilnidipine. All these are non-DHP. Okay, so these block signal at the AV node, and hence they slow the ventricular rate. Okay, so this is used in chaotic atrial signal being organized by AV node. So these are like the extra point that you need to know. Okay, these are mainly used for nodal entry arrhythmias, which means you want to prevent arrhythmias going from SA node to AV node. No? So you want to have block at AV node. AV node is like the checkpoint. Okay, it is like a check post. Okay, so that's why you use this. Next, yes, I think I have discussed everything. We'll go to the questions. Okay, so class 1 is sodium channel blocker. We have phase 1 depolarization is blocked. Okay, that is involving sodium channels. So we are dividing into 1A, 1B and 1C. So yes, 1A is moderate block, increased action potential duration. Yes, what is the mnemonic? QPD, quinidine, procainamide, and one is diisopyramide. Next, class 1B, I told you L and M. That is, L is for, M is for mexiletine and L is for lidocaine or lignocaine. 1C is strong but no APD change. Okay, we saw that it is also contraindicated in like structural heart diseases. Here we have F and P, that is flecainide, and we have propafenone. Okay. Next, class 3 are what? Potassium channel acting drugs. Okay, we have amiodarone, sotalol and dofetilide. Okay. Class 4 we have calcium channel blockers which act on AV node. Okay. So AV node conduction is delayed or inhibited. Next, what dash shows all class action, that is 1 to 4, which is that drug? Yes, amiodarone. Amiodarone is a very important drug. Dash drugs are used for post-MI ventricular arrhythmias. I told you post-MI, which means they have shorter action potential duration. Those are class 1B, which are the lidocaine and mexiletine. Okay. Next, class dash are contraindicated post-MI or in LV dysfunction. Which are these drugs? 1C. Remember, no? 1C drugs are contraindicated. Dash causes pulmonary fibrosis and thyroid dysfunction as side effect. Yes, these are side effects of amiodarone. Remember, amiodarone can cause hypothyroidism. It can cause pulmonary fibrosis also. What is the drug of choice for SVT, supraventricular tachycardia due to AVNRT? That is atrioventricular non-reentrant tachycardia. Okay, so drug of choice whenever it comes to SVT because of any AVRT or AVNRT. Okay, AVNRT is AV nodal reentrant tachycardia. Okay. So here always the drug of choice becomes adenosine. Now we'll ask me, adenosine is a drug of choice for SVT, that is supraventricular tachycardia. You have seen in many cases that adenosine. Then why isn't adenosine not mentioned in any of this class 1, 2, 3, 4? There is no mention of adenosine at all in this. It's such an important antiarrhythmic drug because adenosine acts not by these channels. It acts by separately. It blocks something known as A2. It blocks A2 channels in AV node. Okay, A2 purinergic channels. A2 purinergic channels in AV node. Okay, so that's why this is known as class 5. So which is class 5 antiarrhythmic, which was newly added, that is adenosine. Now, if increased refractory period is there, that is, which is the refractory period? This is the refractory period. So if that is increased, then it is class 3. Okay, potassium channel. Monitor QT interval risk for torsades risk with which class drugs? I told you which class increases QT interval. Yes, very good. It is class 3. So I think after this you shouldn't have any doubt regarding antiarrhythmics. Everything should be clear, crystal clear. Okay. So next we'll go to sodium nitroprusside. So sodium nitroprusside is an anti-hypertensive drug which is used in case of hypertensive emergency. It is almost similar to nitrate only. It is a type of nitrate only because it has sodium nitroprusside. Nitrate group is there. So it causes same thing. That is, it causes nitric oxide release, guanyl cyclase, increased CGMP. It causes smooth muscle relaxation. It causes venodilation. It also causes arterial dilation, and it causes rapid BP drop because it has both action. Unlike glycerol trinitrate, which is more of venodilation, this has arterial dilation also. So this is used in case of hypertensive urgency and hypertensive emergencies. Okay, hypertensive urgency and emergencies, sodium nitroprusside becomes a drug of choice. Now you give it through IV infusion only. Okay, it is not an oral drug. It has very immediate immediate onset of action, and it also has a very short duration of action. So it is used for hypertensive emergencies. It is used in acute heart failure to rapidly lower BP, and it causes reflex tachycardia, just like our nitrates. It causes reflex tachycardia. Okay, because of sudden hypotension. Now, important thing is this is always sodium nitroprusside is a photosensitive drug, hence it is wrapped in light sensitive, and even the IV covering is also wrapped in dark paper or silver foil. Next, it should be titrated very slowly. Okay, and you have to monitor BP. Why? Because it also has tachyphylaxis. Which is similar to tachyphylaxis, okay, which is similar to nitrates. Okay, and when combined with beta blocker, it will reduce the reflex tachycardia caused because of this sodium nitroprusside, and hence that is beneficial. Okay, so one important drawback of this glycerol trinitrate is cyanide toxicity. Drawback of sodium nitroprusside is cyanide toxicity. Okay, which was not there for GTN. Okay. So what this does is this sodium nitroprusside, it decomposes into cyanide and thiocyanate. Okay, so this cyanide, okay, and it will decompose into cyanide and thiocyanate. Okay, so this cyanide toxicity can develop with overuse, and for this antidote is, what is the antidote for cyanide? Yes, it is very important, sodium thiosulfate. Okay, sodium thiosulfate is the antidote of choice. Okay, so this is the one more extension of MCQ that you can get. Okay, so important thing is sodium nitroprusside we won't use for chronic use. It is used for acute lowering of BP only. It should be avoided in renal and hepatic failure because its excretion is affected, and do not mix this with other drugs because it is highly unstable. One more rare side effect is methemoglobinemia. Okay, methemoglobinemia. Actually, I had a case when I was third year resident in PICU. We had a case where there was a child with chronic glomerular nephritis. We were suspecting RPG, and that was rapidly progressive glomerular nephritis. So because of that, the child had hypertension. Okay, and she went into acute, she went into hypertensive urgency. Okay, and then we had to lower BP immediately. So we had given sodium nitroprusside, but somehow toxicity developed, and she went into methemoglobinemia. Okay, so then we had to treat methemoglobinemia also. So what is the drug of choice for methemoglobinemia? Yes, very good, it is, yes, very good, it is methylene blue. Okay, IV methylene blue. Actually, I had seen two cases of methemoglobinemia. One was this case, and second was a patient of malaria. Okay, who actually was given primaquine, and because of primaquine, okay, primaquine is also a drug responsible for methemoglobinemia, and she also developed. The thing was, when the patient came, she was treated somewhere outside, and when the patient came to us, her saturation was not maintaining, even despite having giving 100% O2, everything, saturation was not picking up. Okay, so then we reviewed the history, drug history, and then there was primaquine, and then we suspected methemoglobinemia. We sent methemoglobin levels via ABG. It is done. Okay, we find methemoglobin levels, and it was on the higher side. Then we had to administer methylene blue, and then patient was fine. Okay, so these are some things that are clinically oriented, which you study here, but when you see in actual practice, you'll be very happy. Okay, so we'll solve the questions quickly. So sodium nitroprusside, remember two side effects. One is cyanide toxicity, and second is methemoglobinemia. So what is the antidote? Yes, sodium thiosulfate is the antidote. Now, it is detoxified by which enzyme? Yes, this cyanide which is produced, no, that is detoxified by rhodanase enzyme. Okay, the name of the enzyme is rhodanase. Next, causes dash at high dose. Yes, it causes cyanide toxicity at high dose. Okay, cyanide toxicity at high dose. Next, drug of choice for aortic dissection along with beta blocker is sodium nitroprusside. Okay, sodium nitroprusside. So chemistry was my favorite subject in my class 11th and 12th. Hence now also when I write some names, you might find that I write chemistry names only because I'm used to it. Instead of writing water as water, I always write it as H2O. For magnesium sulfate, even in my notes also, sometimes in my patient notes also, I just put it as IV magnesium sulfate, this much mg. So it has become a habit. Okay. Yes. So we'll go to next topic, that is we'll go to hematology now. Okay, hematology, that is we are going to antiplatelet agents. So moving to next topic, that is antiplatelet drugs. Okay, so here we have a lot of questions which are getting repeated again and again, so your concept should be very thorough. Okay, so we should know first what are the two types of platelet blocking drugs that we have. One is which blocks activation of platelets. Activation means when platelet have these granules, they will be released. Okay, and that causes various function of this clotting and all. Okay, so this is known as platelet activation blockers. And second is which blocks aggregation of platelets. So once platelet come nearby, they'll aggregate and they'll block the clot, right? So that is by platelet blocking aggregation. Okay, so finally both the action will be to prevent thrombosis, that is to prevent clot formation. Now, which are the different type of platelet blockers we have? One is we have COX-1 inhibitor. So COX-1 is an enzyme, cyclooxygenase 1. Okay, so the classic case is aspirin. So what happens is aspirin blocks this COX-1 enzyme. COX-1 actually produces thromboxane E8-2. Okay, so with the inhibition of this thromboxane E8-2, thromboxane E8-2 is a platelet aggregator and it causes vasoconstriction and all. So basically it leads to clot formation. So aspirin prevents it by inhibiting COX-1 enzyme. Okay, very good. Yes. Second is this P2Y12 inhibitors. We'll see what this P2Y2 are, okay. So what happens is there is a receptor on platelet known as P2Y2. This ADP is a molecule which acts on this P2Y12 receptor, okay. More in detail we'll study under physiology. So here this is what you should know. P2Y12 inhibitors are clopidogrel, which is the prodrug, okay. This clopidogrel is activated, prasugrel and ticagrelor, okay. So this whatever GREL, GRE, okay. So these are P2Y12 inhibitors, okay. Third is GP2B3. This is basically what anchors this receptors to the platelets, okay. So this is the endothelium cells. From here platelet this one is binding, that is by this GP2B3A receptors, okay. So in between we have fibrinogen which connects the platelets, okay. So this blocking step is done by this GP2B3A receptors, which are abciximab, eptifibatide and tirofiban, okay. But remember abciximab, which is the prototype drug, then we have eptifibatide and tirofiban. I know all these things are very difficult to remember. Next is this PDE, phosphodiesterase inhibitors, that is one is silastazole and dipyramidol, okay, not much useful, okay, in this case. Next is new drug, that is a protease activated receptor 1 inhibitor that acts by inhibiting thrombin, okay. So thrombin is thrombin receptor is inhibited here, okay, so because of this drug. So this is also a new drug, that is Vorapaxar, and then we have prostacyclin analogs, that is iloprost, okay, which causes vasodilation also, and it increases platelet activity. So if you ask me which are the most important drugs you need to remember for your upcoming exam, one is this P2Y12 inhibitors and GP2B3A inhibitors. These two are very important. Along with that, remember this Voraxaporo also, okay, which inhibits thrombin. Now, what are the important things that you should know? See, first is dipyramidol. So this is dipyridamole, okay. So this has weak antiplatelet action, okay. So it's not very much useful in acute coronary syndrome because it is not for emergency management. It is basically used for prevention, okay. Prevention, especially in stroke and TIA. Clopidogrel, which we use frequently when during MI and during stroke also. So what happens is this is actually used in this is a prodrug which is metabolized by CYP2C19 enzyme. So in those people who have this poor metabolizer, so in them this prodrug is not useful. There we can give prasugrel or ticagrelor, okay. Next, aspirin is causes GI bleeding. That action is not because of thrombocytopenia. Remember, it is not because of thrombocytopenia. It is mediated via COX-1. So for aspirin, it is via COX-1 because in if you remember the gastric barrier, okay. So there are prostaglandins which actually help in maintaining gastric barrier, okay. But what this COX-1 does is it will inhibit this prostaglandin, and hence this gastric barrier is lost, and that's why there is GI bleeding. And GI bleeding in aspirin is not because of thrombocytopenia. It's a very important concept clearing topic, okay. Next, rare topic, prasugrel is contraindicated in stroke and TIA. The reason is simple, because this prasugrel actually causes lot of a very strong antiplatelet effect. So there is a chance that it can cause intracranial bleed. That's why prasugrel is contraindicated in stroke and TIA, okay. Next, ticagrelor has causes dyspnea via adenosine effect. So these two drugs, which are P2Y12, you will have to remember these two side effects, these two things, that is prasugrel is contraindicated in stroke and TIA, and ticagrelor causes dyspnea. And this dyspnea is mediated by adenosine effect, which you shouldn't know. Just remember that one of the side effect is dyspnea, okay. Now, post-stent, this dual antiplatelet therapy is very useful. The most common combination that we use is one is aspirin, that is COX inhibitor, and second we use a P2Y12 inhibitor. Mostly we'll use clopidogrel, okay. So this clopidogrel and aspirin combination is used post-stent in MI to prevent any risk of clotting, okay. Next, low dose aspirin. Actually, aspirin has very differential dosing. It has low dose, it is preferable in as antiplatelet action, and higher dose we use it for inflammatory action, okay. So aspirin low dose is antiplatelet, higher dose we'll use it for anti-inflammatory purposes. So this is how you remember certain things. See here, P12Y12, P blocked by clopidogrel, okay, which is a prodrug. So this is how you remember. CYP2C19, okay, somewhere E is also there, just remember this much. Next, aspirin A means it blocks the COX-1 enzyme, okay. Next is the final aggregation step, that is GP2B3A, that is blocked by GP2B3A, which one? So first is thromboxane A2, which aspirin blocks. Second is ADP, which clopidogrel blocks. And final step, that is GP2BA, that is aggregation step. Okay, see here, this is the aggregation step. Okay, and this is blocked by GP2B3A, that is blocked by which drugs? Yes, very good. Those are apixaban, eptifibatide, and tirofiban. Okay. So these things will come again. One is in physiology and second is in pediatrics, where we'll be discussing von Willebrand disease, we'll be discussing Bernard-Sollier syndrome, we'll be discussing and Glanzmann thrombosthenia. Okay, so all these are also related to these receptors only. So we'll quickly solve MCQs. Dash inhibitor is aspirin. Aspirin is which inhibitor? COX-1 inhibitor. Okay. Dash inhibitor is clopidogrel, prasugrel, ticagrel, or yes, it is P2Y12. This is the most important class of drugs we have. And dash is reversible in this. Okay. One drug is reversible, that is ticagrelor. Okay. Ticagrelor is reversible. Next, PDE inhibitors, okay, which are not very important for us. It is used in claudication also. Okay. So which is used? Silastazole. Silastazole is a PDE inhibitor, which has actually antiplatelet effect, but it is also used in claudication. Next, PAR1 antagonist. I told you, protease activating receptor 1 antagonist. What is that? Voraxapar. Okay, it's a new drug, Voraxapar. Next, prostacyclin analogs are used in PAH also. Okay, pulmonary arterial hypertension. Next, GP2B3A. It is a final blocking pathway because it blocks aggregation. Okay. Dash inhibitors have highest bleeding risk. I told you these are GP2B3A. Okay, GP2B3A inhibitors have highest bleeding risk. Okay, which are the example? Axicimab, Eptifibi. What is that drug? Here, yes, eptifibatide and tirofiban, Axicimab. These three drugs. Okay. Next, last question. Dash is contraindicated in stroke and TA. Remember which I told? Prasugrel. Prasugrel is contraindicated because it has strong antiplatelet action, so it can cause intracranial hemorrhage. Okay, so rest of the things are the same. Aspirin low dose 75 to 150 mg preferentially blocks thromboxane A2. Okay, higher dose it is used for anti-inflammatory action. Yes. Next, anticoagulant mechanism of actions we'll be seeing next. So once we have went through antiplatelets, our next target is this anticoagulants. Okay. So first what happens is, first there is, what are the three steps of hemostasis? Hemostasis, not homeostasis. Okay. Hemostasis means blood clotting. First is vasoconstriction, first thing. Second is platelets, whatever they do. And third is coagulation cascade. Okay. So this is the step. Okay. So first we saw antiplatelet drugs. Now we'll be saying anticoagulants which are there. Okay. So first platelet plug is formed. After that it is followed by activation of something known as factor 10A. Okay. So factor 10A activation occurs from two pathways. One is intrinsic pathway and the extrinsic pathway. So we'll be discussing this in detail once we discuss physiology. Okay. So the final pathway of this intrinsic pathway, the final molecule is factor 10A. 10A leads to activation of thrombin, that is prothrombin 2 to 2A thrombin. Okay. So once thrombin is activated, then it leads to activation of fibrinogen, which is factor 1, and then it leads to fibrin clot. Okay. Now there are certain molecules like antithrombin. So now we'll look into what exactly each drug, where it acts. Okay. So first is unfractionated heparin and second is low molecular weight heparin. Okay. So these two have different mechanism of action. UFH, okay, it mainly inactivates this 2A and 10A. Okay. So this is 2A, which is there in green, and this is 10A. Okay. So it inactivates both. Okay. So 2A, 10A and antithrombin 3, these three. Okay. Whereas low molecular weight heparin, it selectively inhibits this 10A. Okay. Preferential inhibition of 10A as compared to 2A, 10A and antithrombin 3. Okay. Similarly, fondaparinux is also 10A inhibition. So remember in your question how to differentiate mechanism of action of UFH and LMWH, it is just with this 2A. 2A inhibition is not done by low molecular weight heparin. Rest all are the same. Even this inhibits antithrombin 3. Okay. Now next, warfarin. Warfarin action is entirely different. Okay. Warfarin inhibits this vitamin K epoxide reductase. Okay. So it's basically going against vitamin K. So it is vitamin K antagonist. So yes, you have guessed it right. Now what will be the antidote for warfarin? It will be vitamin K. Okay. Now direct thrombin inhibitors means directly it will inhibit this factor 2. Okay. So these are examples for these are Direct thrombin inhibitors, that is factor 2 inhibitors are, okay, direct thrombin inhibitors, we call it as DTI. One is argatroban and second is dabigatran, okay. Sorry, yeah, dabigatran. And one more is bivalirudin, but I think you don't have to know. Just argatroban and dabigatran you will have to remember. Then there are something known as direct 10A inhibitors. Direct 10A inhibitors, 10A, okay. So it is rivaroxaban, apixaban. See what is common here? 10A. So whenever you get 10A, so 10A is banned, okay. Banned means it is inhibited. So that is how you remember this, okay. Argatroban, dabigatran, and here you will get rivaroxaban and apixaban. How to remember this? What is thrombin? What is factor 2? It is thrombin, no? So you'll get TR, thrombin, okay. So that is how you remember. Now, what are the other things that you should know? First is, for heparin monitoring, you use APTT, okay. APTT is intrinsic pathway. You use it for heparin monitoring, and for warfarin monitoring, you use PTINR, okay. PTINR is extrinsic pathway, okay. Now, what is DOAC? DOAC is directly acting anticoagulant agents. So these are basically the drugs which directly act on, these are oral drugs, okay. So right now we have a combination such as dabigatran, we have rivaroxaban, which are oral, but these are not very frequently used, okay. So routinely we don't use. Our main targets are warfarin, okay, and heparin, okay. Next, which are the reversal agent? In case of protamine is for what? Heparin. So heparin toxicity will use protamine, okay. Second, for warfarin, what we use vitamin K. So this is for warfarin, okay. And what is used for idarucizumab? Okay, what is this idarucizumab? You know what is dabigatran? See, actually in this name only it is there, idarucizumab, okay. So see here, dabigatran. So which is dabigatran? Dabigatran is direct thrombin inhibitor. So in case of dabigatran toxicity, the antidote is idarucizumab, which is a monoclonal antibody, okay. It is a specific antidote for dabigatran, which can be asked in INICET. Now, what is the management flow chart? If there is bleeding after giving oral anticoagulant, then you have to give antidote, okay. So that is the frequently asked next step of management question. So there are some things which you should know. One is HIT. HIT is nothing but heparin induced thrombocytopenia, okay. So what will happen is, because of heparin, there will be some antibodies that are created which will cause thrombocytopenia, okay. So this is known as heparin induced thrombocytopenia. Actually the antibodies are against platelet activating factor 4, okay. So against this, so it is against platelet factor 4, okay. Next important thing is, when you give heparin, heparin is given via IV route, okay. So when do you give heparin? Heparin you give any time there is some thrombosis. Let's say like there is stroke or there is some DVT. So initially you give heparin, like you give LMWH, that is low molecular weight heparin. Unfractionated heparin we don't use nowadays, except I think in post cardiac surgery only. That time is that is the time when we prefer UFH. We don't use routinely. But LMWH, the other name is enoxaparin, okay. That is the trade name. So this we prefer very frequently, okay. You might have seen during your internship prescribing enoxaparin. It is a subcutaneous injection, okay. So what will happen is, if you give warfarin, what will happen if you give warfarin on day 1? Warfarin we don't give, because warfarin takes around 7 days to act, okay, 5 to 7 days. That is because initially there will be some store of this vitamin K epoxide reductase enzyme which will actually do its function. So that's why we bridge low molecular weight heparin along with warfarin, and then we'll see the effect. Similarly, after giving warfarin, we'll monitor PTINR levels. Remember, LMWH we don't use levels that frequently, okay, but for PTINR we use very frequently for warfarin, okay. So always remember, in warfarin, when we are giving warfarin, we monitor the levels of warfarin not directly, we use PTINR indirectly, and we keep the levels as 2 to 3. So INR should be between 2 to 3 whenever we give warfarin, okay. Next, protamine neutralizes UFH, not fully LMWH. You know that protamine sulfate is the antidote for heparin. So for unfractionated heparin, it is very useful, but in low molecular weight heparin, it is partially effective, okay. So one more thing is, during pregnancy, Warfarin is contraindicated because it causes warfarin embryopathy, okay? But heparin is safe during pregnancy, so that is a drug of choice, okay? Next, in fondaparinux, another thing is we saw that when we give low molecular weight heparin or unfractionated heparin, there is risk of heparin-induced thrombocytopenia, no? But that risk is not there with fondaparinux because fondaparinux is directly so it is actually 10A inhibition only, but not directly. It is indirect inhibition via antithrombin 3. Okay, so that is what you need to remember. Mechanism of action is almost same as low molecular weight heparin. Now there are few important things which will be asked in the question, whether it is true or false type of questions. Okay, so what is warfarin skin necrosis? Whenever there is warfarin toxicity, what it does is it causes coagulation to occur in the blood vessels and all. Okay, so there will be rapid drop of protein C and S, and that causes skin necrosis. Okay, so that is the side effect of warfarin toxicity. Second is heparin bolus plus infusion. So the meaning of this is that first we give a bolus, that is like a loading dose, which will actually give immediate anticoagulation, and then we maintain the same dose with infusion. Okay, so that we maintain same levels. Okay, that is the meaning of it. Very important, whenever we give anticoagulants, we don't give via IM route because there will be risk of hematoma. Okay, there are few things you need to remember. See here, this police. Okay, police is arresting what? 2A. 2A is thrombin and 10A is 10A, okay, factor 10A. So these two inhibition actually causes anticoagulation. Okay, now 2A, we saw that 2A is seen in case of UFH. So anticoagulation means either inhibition of 2A thrombin or 10A factors. Okay, now it can also enhance activity of antithrombin 3. That means antithrombin 3 is an anticoagulant. So antithrombin 3 is actually an anticoagulant only. Okay, so all these factors are coagulants. Antithrombin 3 is an anticoagulant only. So increased activity of antithrombin 3 will actually will prevent coagulation. Okay, so warfarin inhibits which factors in liver? Actually 4 factors are produced: 2, 7, 9, 10, and this is a repeatedly asked question. Okay, 2, 7, 9, 10. It prevents the gamma carboxylation. Okay, gamma carboxylation of these factors vitamin K will prevent, warfarin will prevent. Okay, next, direct thrombin inhibitors, I have told you so far. Okay, so let's solve the questions. Binds dash accelerates inhibition of 2A and 10A. This is nothing but unfractionated heparin because both 2A is also there and 10A is also there. Next question. Okay, HIT antibodies against heparin and what complex? Sorry, we had gone through wrong fill in the blanks. It was for the next chapter, so this chapter will go. Dash binds antithrombin 3, it is, yes, UFH or heparin. Okay, heparin binds antithrombin 3. Okay, next, and inactivates 2A and 10A also. Dash enhances antithrombin 3 and preferential inhibition of 10A but no inhibition of 2A. Yes, very good. LMWH, it is also known as enoxaparin. Okay, next, fondaparinux, I told you, it has mechanism of action similar to LMWH. It is selective 10A inhibition only. It's a synthetic pentasaccharide. Okay, just remember this one point. Next, warfarin, vitamin K antagonist, inhibits gamma carboxylation of what? It inhibits gamma carboxylation of which factors? 2, 7, 9 and 10. Okay, next, direct thrombin inhibitors. Which are the direct thrombin inhibitors? Yes, I told you, direct thrombin inhibitors are the one which have TR in their this one. Okay, thrombin TR. So dabigatran, yes, very good, dabigatran. And one more we have, that is, yes, argatroban. Okay, dash inhibitors are rivaroxaban, apixaban, endoxaban. See here, 10A. So these are direct 10A inhibitors. Okay, direct 10A inhibitors. Monitoring, for heparin we use APTT, warfarin we use PTINR. Reversal, heparin reversal, yes, very good, protamine. Okay, protamine sulfate will use. For vitamin K we'll use for warfarin we use vitamin K as antidote, and for dabigatran we use idarucizumab. Okay, idarucizumab. Okay, next, warfarin is contraindicated in pregnancy. Yes, because it causes warfarin embryopathy. Okay, next, dash is oral reversible direct thrombin inhibitor approved for atrial fibrillation. Okay, AF is atrial fibrillation prophylaxis. Yes, so direct thrombin inhibitors, I told thrombin means TR, so which is that? Dabigatran. Okay, dabigatran. Next, Drug of choice for DVT in pregnancy. Okay, pregnancy it is. Yes, very good. Heparin, low molecular weight heparin. Okay. If APTT monitoring, you have to think of heparin again. Okay. Next, dash does not cause HIT and can be used in HIT. What doesn't cause? Fondaparinux. Okay. I told you, fondaparinux doesn't cause HIT. Okay, that is heparin-induced thrombocytopenia. We'll also solve these questions. Okay, these are similar to that previous only. Dash binds and accelerates inhibition of 2A. I told you this is, sorry, the mechanism of action of heparin is heparin binds to antithrombin 3. Okay, here answer is antithrombin 3. Okay, heparin binds to antithrombin 3 and accelerates inhibition of 2A and 10A. Next, heparin-induced thrombocytopenia. I told you it is against platelet factor 4. Okay, rest of the things, I think most of the things are repeated, so you can just skip this. So same thing again, we'll just have a brush up. Heparin will activate antithrombin 3, which will lead to inhibition of thrombin, that is 2A, and factor 10A, okay, and which prevents a clot propagation and fibrin block. Now, unfractionated heparin blocks 2A and 10A both. APTT monitoring is required. LMWH blocks only 10A, hence we don't require any monitoring. Okay, so no routine monitoring is required. Now, clinical uses we'll give in the form of bolus and IV. I think all these things I have explained. Okay, there is nothing which is not explained. Yes, everything is explained. Okay, monitor platelet levels if you are suspecting a heparin-induced thrombocytopenia. Okay, rest all I have told you. Okay, you can go through it. Now, one more small, a few more points on low molecular weight heparin. That is, no routine APTT monitoring is required for low molecular weight heparin. Okay, and dash assay if needed, we do 10A factor assay. Okay, so this 10A factor assay we do in case of we require LMWH monitoring. Okay, next, elimination is by kidney. Okay, that's why whenever there is whenever there's renal impairment, especially in CKD or AK, we have to lower the dose of LMWH. Next, drug of choice for DVT prophylaxis post surgery is LMWH. Okay, next, stop dash hours before surgery to avoid bleeding risk. We stop this 24 hours before surgery. Okay, rest of the things are the same. We can go through the content. Okay, so here also we have same thing, LMWH, which are short chains. They will activate antithrombin 3, which is a natural anticoagulant. That in turn inhibits 10 and 2A. Okay, so 10A is also inhibited and 2A is also inhibited, but 2A is weak inhibition. Okay, unfractionated heparin causes strong inhibition of thrombin 2A. That is a difference. Okay, so selective 10A inhibition via anti-3 prevents clots. Okay, long T half once day, that's why only once or twice daily is recommended. We do by anti-10A assay if needed. Okay, next, renal adjustment dose I have told, and it is safe in pregnancy also. We don't give warfarin in pregnancy, we give LMWH in pregnancy. Okay, next, the trade names are enoxaparin and dalteparin. Next, there is it should not be used intramuscularly. Okay, so it is used via subcutaneous route. Antidote is protamine. Okay, but it causes partial reversal only. We discussed this also. In case of UFH, it causes complete reversal. Next, it is used as bridging therapy for warfarin. Stop 24 hours before surgery. Less HIT, heparin-induced thrombocytopenia risk, and if anyone asks you, pure 10A inhibition, that is caused by fondaparinux. Okay, it's a pentasaccharide variant. Next, DVT prophylaxis, we use LMWH. Okay, and monitoring test is anti-10A factor 10A. Okay, I think all this I have discussed. Next, we'll go to the next topic, that is reversal of anticoagulation. Again, a very common. So warfarin acts via which inhibitor? It is vitamin K. This is very important question. It is repeated many times. Vitamin K epoxide reductase. Okay, this is the enzyme epoxide reductase. Inhibition is a mechanism of warfarin that causes decreased levels of 2, 7, 9, 10. Okay, these are level dependent factors. Okay, next, dabigatran. It is a recently asked question. Okay, direct thrombin inhibit, that is dabigatran, which is the drug that is used to reverse dabigatran toxicity. It is idarucizumab. Okay, idarucizumab. Next, rivaroxaban and apixaban, which are 10A inhibitors. Okay, factor 10A direct inhibitors, which is the thing that is used, that is same again. Reversal agent is andexanet alpha. Okay, andexanet alpha. So here also you will find XA, that is 10A. Okay, so reversal we use andexanet alpha. Okay, this is the answer. Next, dash rapidly reverses dabigatran within minutes. Yes, idarucizumab. Idarucizumab. Next, do not give dash in fish allergy or vasectomy. So in case of fish allergy, that's why you'll see that for protamine, we have this fish symbol. That is because it is derived from a fish. Okay, so in case of fish allergy, we don't give protamine. Okay. Okay, this is a rare question that can be asked. Okay, not common question. So I think I have answered everything. Okay, and hexanate alpha. Okay, fine. Okay, so this is the reversal of anticoagulation. I wanted to focus only on these things: heparin, UFH, and LMWH. We use protamine. In this case, it is complete neutralization, and here it is partial reversal only. For fondaparinux, there is no antidote available. For warfarin, we know vitamin K and plasma cell concentrates like plasma concentrates. Okay, like FFP, all these are used. Okay. Next, dabigatran, that is direct 10A inhibitor. Idarucizumab is the reversal agent, and for 10A, that is rivaroxaban, and andexanet alpha is the reversal agent. Okay, I think everything I have explained in this. Okay, so you can go through this. Next we'll go to CVS, that is statins. Okay, as HMG-CoA reductase inhibitor. There are many questions asked on this. So this is the image part of statin. So basically, what is statin? Statin is a competitive inhibitor. Okay, very important. It's a competitive inhibitor of HMG-CoA reductase. Okay, this comes under cholesterol synthesis mechanism, and this is the rate limiting step of cholesterol synthesis. So cholesterol synthesis happens in liver. So this mechanism also, statin mechanism also happens in the liver. Okay, so it causes upregulation of LDH receptors, as a result of which increased LDL is internalized into the cell, and there is decreased LDL in the plasma. Okay, that is a major effect of statins. So which are the common agents? Yes, we have atorvastatin, rosuvastatin, simvastatin, pravastatin, and lovastatin. And we usually give evening dose, that is during sunset dose, except atorvastatin and rosuvastatin. This is a question based on pharmacokinetics. So atorva and rosuva. Other than this, we give all statins during evening dose. Site of action is, again I told, hepatocytes. This statin is involved in CYP3A4 mechanism. That's why it can cause interactions. Okay, it is hepatic excretion. Okay, renal excretion is mild, so it can be safely used in renal failure. Next, additional benefit, it also, in addition to decreasing LDL levels, it also causes plaque stabilization. Like, it doesn't promote plaque rupture, it stabilizes the plaque, and it is anti-inflammatory also. Okay, so statin stopper and receptor catcher. So statin inhibits this enzyme HMG-CoA reductase, completely inhibited, decreased cholesterol synthesis. So increased LDL receptors, which are like catchers, they'll catch the LDL which is there in the blood, and it will lower LDL levels. Okay, next, rosuvastatin is the most potent. How do you remember this? Rose is potent. Okay, that's why you have image of rose. Rose is the most potent like flower. It has very good smell, aroma. So rosuvastatin is the most potent. And pravastatin bypasses CYP, hence it has fewer interactions. So this is like a CYP tunnel where this P stands for pravastatin, that walks into. So it bypasses CYP metabolisms. Okay, rest all go through CYP3A4. It is taken at sunset, evening dose. Okay, because nocturnal synthesis, because cholesterol synthesis is highest in the liver at night. Okay, so that's why we prefer night dose. So it's a very specific question. Examiners are fond of these exceptions. Okay, that's why remember, statin means at night. Next, what does this MAC do? MAC are the drugs. So this MAC drugs, that is macrolides, azoles, and cyclosporine. These two are, remember, antibiotics. Okay, macrolides and azoles. Azoles are antifungals. Along with this cyclosporine. Okay, cyclosporine is immunomodulator. These three drugs, they are known to cause rhabdomyolysis. So statins are also known to cause rhabdomyolysis. So along with statins, you will have to avoid these drugs. Okay, otherwise it will precipitate rhabdomyolysis. You can also expect questions like, after starting of statin, there were some, like the patient landed up in acute kidney injury, or he had myoglobin in the urine. Okay, so something like that, and he had hypocalcemia, all those things. So those are related to rhabdomyolysis. So this is an integrated topic with medicine. So lipid profile effects. Statins have a major impact on LDL. LDL is a major lipoprotein that will decrease. Second is a moderate decrease in triglycerides also, and mild increase in HDL. That's why you'll see, even when triglycerides are high and LDL is normal, we don't start statins. Okay, the only indication for starting is very high LDL levels. Okay, next, fatal traps. Some places where you go wrong is, one is contraindications in pregnancy and liver failure. Actually, This drug statin is contraindicated in pregnancy also, and it is also contraindicated in liver failure because you know that it has hepatic excretion, hepatic metabolism. Next, drug interaction toxicity. If you give along with fibrates, fibrates are one more drug which reduces like it's used for weight loss and all. Okay, basically for decreasing. Fibrates are used in severe hypertriglyceridemia. So when you give this along with statin, then it can cause rhabdomyolysis. So you don't usually combine both. You never combine both. Okay. Next, decreased CRP. It is an independent effect of statins. Okay, decreased CRP. In terms of potency, I told you rosuvastatin. Rose, you know, no? Okay, I showed you that is the most potent, and fluvastatin is the least potent. Okay. So what you have to monitor when you go through, when you give statins, one is LFTs you'll have to monitor, and second is CPK for rhabdomyolysis. Okay. Next, stop temporarily whenever there is infection or during surgery. Lifelong it is given in case of coronary artery disease because it prevents secondary by stabilizing plaque and by having anti-inflammatory and cardioprotective actions. Most protective rosuvastatin, CYP independent pravastatin. You remember that P no goes into the tunnel. And similarly, myalgia is caused by statin toxicity. Okay, so all these are very high yield topics, all explained in a single slide. Now let's solve questions. So effect on lipids, LDL is major decreased, okay, and triglycerides is moderately decreased, and HDL is mildly increased. Site of action, what is the site of action? It is liver, okay, it is liver. Next, DASH is least potent, rosuvastatin is most potent, least potent is fluvastatin, okay. Fluvastatin is least potent. DASH is not CYP metabolized, I told you, which P. P is what? Pravastatin. Okay, that tunnel you remember now. So P, pravastatin. Next, avoid with macrolides, azoles and cyclosporine because it increases risk of rhabdomyolysis. Next, do not combine with fibrates, again risk of rhabdomyolysis. Most potent LDL lowering drug, yes, Rose. So it is rosuvastatin. Very easy, right? Now you guys will never forget these things. Okay, rest of the things you go through. Next important topic is mechanism of action of antihypertensives. Very important topic again, and we have a lot to discuss here. Okay, so first we'll see why hypertension occurs. What is the core physiology? So basically what happens is whenever there is decreased circulating blood volume or release of this like adrenaline and all these vasopressors, there is increase in renin angiotensin activating system, as a result of which this secretes angiotensin. Okay, so this angiotensin 2, which is a potent vasoconstrictor, this is responsible for this increasing total peripheral resistance. Okay, so peripheral resistance is increased, so vasoconstriction occurs. Okay, now what does antihypertensive do? One mechanism, it decreases renin angiotensin mechanism by various mechanisms, and second is it will decrease total peripheral resistance also, causing arteriolar dilatation. Okay, so we have various group of drugs also. So first is ACE inhibitor. So ACE inhibitors, as the name suggests, it inhibits ACE enzyme. So what is ACE? ACE is angiotensin converting enzyme. So angiotensin converting enzyme converts angiotensin 1 to angiotensin 2. Now what happens is, a side effect of this drug is when angiotensin like ACE inhibitors doesn't metabolize angiotensin 1, right? Similarly, it doesn't cause breakdown of bradykinin. Okay, in the lungs, basically this ACE enzyme ACE, it inhibits this production of bradykinin. But now what happens? Bradykinin is increased because ACE is inhibited. In kidney it will do this one, okay, in the lungs it will do this. Okay, so you shouldn't get confused. So a common side effect of this ACE inhibitors is cough. Okay, what is the prototype drug? Yes, we have captopril. Captopril is the prototype drug for ACE inhibitors. One more thing you will have to remember is there are three main contraindications for ACE inhibitors. One is bilateral renal artery stenosis, second is hyperkalemia, and third is pregnancy. So if these three are there, this is more than 6, okay, hyperkalemia. So if these three are there, then ACE inhibitors are contraindicated. Second is renin inhibitor. So renin means directly what does angiotensin do? It will activate renin. Okay, so directly we are inhibiting this renin. So this is the second mechanism through which antihypertensives act. So this renin inhibitor is aliskiren. Okay, so renin will actually cause activation of angiotensinogen to angiotensin. No, so this renin will actually, inhibition of renin will prevent it. Okay, so this is direct renin inhibitor. Third is a calcium channel blocker. So there are two type of calcium channel blockers: DHP, dihydropyridines, and non-dihydropyridines. Non-dihydropyridines will use in like diltiazem and verapamil. We saw under anti-arrhythmic drugs. Here we have DHPs. Prototype drug is amlodipine. We have other nifedipine. We have nicardipine. We have cilnidipine. So what they do is in arteriolar, okay, arteriolar smooth muscle, it causes calcium channel blockage, okay, as a result of which otherwise this will contract, now it will not contract, so it will cause vasodilation. So this is a mechanism of decreased total peripheral resistance, okay. A side effect of this is it causes peripheral edema, okay. So this can be asked in your question. Now there are a few more one point left under ACE inhibitor. These ACE inhibitors are renal protective, okay, so that's why we give ACE inhibitors in diabetics, because it will decrease proteinuria and it is contraindicated in pregnancy, as I told you. Next is diuretics. So diuretics act on kidney. It will decrease the overall circulating volume. It will decrease reabsorption of sodium and chloride, so that's why it will cause decreased circulating volume. But there's one problem with this, that is it will cause hypokalemia, because when it decreases sodium absorption, it will increase potassium excretion also. That's why it will cause hypokalemia. So this is the best initial therapy in elders, this diuretics, okay. And one more important is, I'll go directly here, that is beta blockers, okay. So this beta blockers, you know that beta 1 receptor we have seen under ENS, it is present in the heart, so it will decrease heart rate, okay. It will also decrease renin from renin angiotensin mechanism. Now I told you that beta blockers, non-selective beta blockers, if you remember, non-selective beta blockers will also block beta 2 receptors which are present, which are required for bronchodilation, okay. Sorry, beta 2 receptors for this, which are required for bronchodilation. So as a result of which, non-selective beta blockers are contraindicated in asthma, because it can precipitate bronchoconstriction, okay. So it also reduces mortality post MI and post heart failure. I told you how, because it will decrease overall sympathetic activity of the body, okay. So these 4 drugs, A, B, C, D, that is A is ACE inhibitor, second is B is beta blockers, C is calcium channel blockers, and D is diuretics. These are known as ABCD of antihypertensives, okay. So these are the most common 4 drugs which are used. Now we'll go to some lesser used drugs. That is, one is, what if we don't act on peripheral blood vessels and kidney, will directly act on the alpha receptors, okay, which are centrally acting alpha 2 receptors, okay. So this will decrease the sympathetic overflow, blocking this receptor, okay. So that there we have clonidine and methyl dopa, which are not frequently used for hypertension, but we use this as add-on for causing antihypertensive effect, okay. And one more important thing is this methyl dopa, which acts via the central acting mechanism, is one of the safe drug for pregnancy, okay, but it also causes sedation. You will have to remember that. Next is angiotensin receptor blockers. I told you that angiotensin 1 gets converted to angiotensin 2. Angiotensin 2 acts on this receptor, AT receptors, angiotensin receptors. What if we block the receptor only, okay? So that is the idea behind angiotensin receptor blockers. And one of the most important drug in this is losartan, okay. Losartan, telmisartan, candesartan, all comes under ERBs, okay. So one important thing is ACE inhibitors actually cause cough. Here the thing is ACE enzyme is not inhibited. That's why we don't have increased bradykinin. So there is no cough, and they are also renal protective in diabetics, just like ACE inhibitors. So ERBs are nowadays a better choice compared to ACE inhibitors. And one more thing is this losartan, it also decreases uric acid levels. So in those patients in whom there is gout along with hypertension, for them losartan is a drug of choice. Next, CCB non-dihydropyridine, that is verapamil and diltiazem. They are also used as antihypertensives, but they are rarely used because they have effect on the heart and they can also precipitate heart blocks. Okay, so we don't use this in severe AV block, and hence we rarely use these drugs. Next is alpha-1 blockers, whose specific side effect is there is only one proper proper indication for this. Sorry, that is in scorpion sting. Okay, in scorpion sting, what happens is there is unopposed alpha-1 vasoconstriction activity because of the scorpion toxin, as a result of which there is severe hypertension. For that condition, we'll use alpha-1 blocker, that is prazosin. In other conditions, that can be some minor indication, but this is the one thing which you need to remember. Same thing, alpha-1 receptor will cause vasoconstriction. It will increase total peripheral resistance, and what alpha-1 blockers do is they will cause vasodilation and they will decrease BP. One side effect of this drug is it can cause first dose syncope, that is because it has a very good action on blood vessels, so it can cause immense vasodilation. Last group of drugs is the vasodilators. Basically these act on potassium channel, okay, and in this we'll get direct arteriolar dilators. So they can cause reflex tachycardia, but one of the drug hydralazine that is safe in pregnancy, and minoxidil is used in hypertrichosis also, okay. So, sorry, minoxidil causes hypertrichosis because it will cause increased blood flow around hair follicle. So it will bring more nutrients to the hair follicle. So it has better growth. The hair follicle will grow better. So it's also used in alopecia areata. Okay, this minoxidil. Okay. So don't think that I'm shedding all this and telling. I'm just explaining you based on what I had studied all this during MBBS days. Okay, so this should be your solid foundation. Okay, so you should know the mechanism, you should know core concepts, and you should know why this side effect occurs and what are the indications. So you'll remember this cough. Cough is for ACE inhibitor, that is because of bradykinin buildup. Okay, next, second, ERB, same benefit but without cough, so we are preferring ERB nowadays. Third is avoid thiazides at low GFR because they are they can precipitate AKI. Okay, AKI and CKD, so we don't use thiazides at low GFR. Methyl dopa is used in pregnancy, and hydralazine is also used. Okay, but we don't use other renin angiotensin blockers. We don't use. Okay, we use hydralazine. Okay, next, amlodipine causes ankle edema. Remember this, amlo, A for A, ankle for amlo. Next, beta blockers, they worsen Prince metal angina. I think I have discussed this already. Next, ACE inhibitors are contraindicated in bilateral renal artery stenosis, which I have already explained. Okay, so specific indications, see comorbidities. If there is diabetes, then ACE inhibitors are protective. Post MIHF, then we'll use beta blockers. In elderly, we'll use thiazides and dihydropyridines. Okay, that is amlodipine, nifedipines. Pregnancy will use methyl dopa and hydralazine. Asthma, avoid beta blockers. Bilateral RAS, avoid ACE inhibitors. And severe AV block, avoid non-DHP plus beta blocker combination. So this one slide has so much information. I think it took me around 10 minutes to explain just this one slide, but it is that important. Okay, next, we'll solve questions now. ACE inhibitors will cause decreased angiotensin 2. Okay, and increased bradykinin, so it will cause what? Cough. So answer here is cough. Next, renin inhibitors. What is the example for renin inhibitors? Yes, it is aliskiren. Okay, aliskiren. Next, DASH is the best initial therapy for adults. It is thiazide diuretics. Okay, next, DASH is safe in pregnancy. Hydralazine and hydralazine safe. Methyl dopa is safe, and you have labetalol also. Okay, labetalol is also safe. Next, DASH is contraindicated in bilateral renal artery stenosis. Yes, very good. It is ACE inhibitors. Which are the ACE inhibitors? Captopril, enalapril, ramipril, and whatever prils are there. Okay, next, antihypertensive safe in pregnancy with the SLE. Okay, so basically what happens in SLE is it causes proteinuria. Okay, so this proteinuria also you should take care of, and you should be taking care of the hypertension part. So here we use methyl dopa. Okay, methyl dopa. Drug causing ankle edema. Yes, very good. Amlodipine. Okay, so we'll go on to the next topic, that is drugs causing pulmonary arterial hypertension. I think we don't have a separate image for this. There are only 2-3 drugs we should remember. One is appetite suppressants such as fenfluramine and all. I think that is not being asked. Very important is one chemotherapy drug that causes pulmonary artery hypertension, that is dasatinib. Okay, dasatinib. Where is dasatinib used? Yes, remember tinib. What is tinib? Imatinib. Remember, imatinib is basically a tyrosine kinase inhibitor. So this tyrosine kinase inhibitor is used in case of CML. Okay, so dasatinib is used in CML resistant, like whenever there is Philadelphia chromosome positive. In resistant cases, we'll use dasatinib. Okay, one more DASH drug was recalled due to pH risk. What is the answer for this? This is fenfluramine. Okay, fenfluramine was a drug which was recalled. Okay, so these two drugs we need to remember. One is fenfluramine, which is an appetite suppressant, and one more is dasatinib. These both can cause PPHN. Okay, sorry, pulmonary arterial hypertension. Okay, next is drugs causing QT prolongation. Again, I think I have gone through some drugs. Okay, one was this antiarrhythmics. Okay, basically all class 1 and class 3, these both can cause QT prolongation. Okay, others are antibiotics. So need to remember macrolide, that is erythromycin and azithromycin, both can cause QT prolongation. Okay, antipsychotics, antidepressants, okay, these also can cause. Next, antiemetic, all these things I think you don't have to remember. So what is basically QT prolongation? QT prolongation is QT interval is more than how much milliseconds? QT interval is more than 500 milliseconds. Okay, so QT, what is QT interval? Say this is ECG, okay. This is P, Q, R, S, T. QT interval means beginning of the Q wave to the end of T wave, okay. This interval is more than 500 milliseconds, that is known as QT interval prolongation. So azithromycin causes less QT prolongation than erythromycin, okay. Dash causes dose dependent QT prolongation, that is nothing but ranolazine. Ranolazine, okay. Ranolazine is a potassium channel opener. So it is not potassium channel opener, it is a sodium channel, late sodium channel blocker, okay. So this ranolazine, it is used in case of angina, okay, but you just need to remember that it also causes QT prolongation in dose dependent manner, okay. Now macrolide with worst QT risk is nothing but it is erythromycin, okay, erythromycin. Now, which electrolyte imbalance causes QT prolongation? Yes, you remember, no, when there is QT prolongation, it can lead to torsidicity pointers also, okay. So this polymorphic VT, which image you are familiar with, that is QT prolongation leading to torsidicity pointers. So one is magnesium and second is potassium. These two electrolyte imbalances can lead to QT prolongation. So whenever a patient or an ECG question is asked where you see QT prolongation and you see torsidicity pointers also, you'll remember two things. One is electrolyte imbalances should be number one thing, okay, that is the most common scenario. Second is drugs causing it. So if you ask me which drugs you should remember, one is this antipsychotics, antidepressant, just remember overall, okay, like antipsychotics, antidepressant, macrolides, erythromycin, class 1A and class 3 antidepressant. These things you'll need to remember along with this one ranolazine, okay. Other things are not required, okay. So see, you can see here, this is normal QT, this is prolonged QT, okay, that leads to high risk of torsidicity pointers, okay. Next, this is the mechanism. See, what happens is why this QT prolongation occurs is because some drugs, they cause this potassium channel block, because of which there is delayed repolarization in the cardiac conduction system. Whenever there is delayed repolarization, it will lead to prolonged this T wave, okay. This big T wave is long T wave is because of this potassium channel blockade, okay. So which are the drugs? Class 1A, class 3, okay. This antipsychotics, antiemetics, whichever is there, okay. Macrolides has the highest risk. Then you have azithro, then you have this antidepressants, okay. And two electrolyte imbalances, potassium and magnesium, okay. Ranolazine causes dose dependent QT increased, okay. So QT increased, think of these 5 broad headings, okay. I think yes, everything is explained in this single slide, so you don't have to go through theory part also. Next we'll go through anti-thyroid drugs and we'll discuss things in detail in anti-thyroid drugs. Okay, moving to anti-thyroid drugs. So basically, to know what anti-thyroid drugs are, their mechanism of action, first you should know how thyroid synthesis occurs. So we'll have a brief overview. So these are the follicular cells of thyroid, okay, thyroid follicles. Now inside these follicular cells, okay, this is the thyroid stroma, okay. So inside the follicular cells, there are some things that are taking place. So basically these are the arteries from blood vessel, blood is circulating, okay. So here what happens is the first step is entry of iodine into this follicular cell. So you can see here iodine enters via sodium iodine symporter pump, okay. So it enters inside. Now this iodide ion undergoes oxidification, okay, oxidification and organification process. If I want to tell you the 6 basic steps so this process is known as iodide trapping, okay. So where this iodine comes inside the cell, and now this iodine will combine with this thyroglobulin, okay. So this process is known as organification, where iodine combines with thyroglobulin, and you can see this iodine residues on this thyroglobulin, okay. Now after this, what happens is this thyroglobulin, it gets converted into MIT, that is monoiodotyrosine, okay, sorry, and diiodotyrosine. Now this will combine, this is known as coupling, okay. MIT plus DIT will form T3 and DIT plus DIT will form T4, okay. So now you have this T3, T4, but which are still bonded to thyroglobulin, okay. Now what happens is there is something called as endocytosis. So these lysosomes will come, they will break this T3, T4 from thyroglobulin, and it will release free T4, T3 into the bloodstream, okay. So this free T4, T3, T4 are the reason for the action. So what happens peripherally is T4 gets converted into T3, and this is by this enzyme deiodinase. So means you are removing some iodine part. Okay, so T4 will be converted to T3. So T3 is the active thyroxine hormone. Okay, so this has all peripheral effects. So what we are measuring in the blood is this free T4 and free T3 levels, which actually tell us. Now you should know that this TSH actually controls this iodine trapping. Okay, so that is under the control of TSH. Now these drugs act at which stage? So there is some drug called as thionamides. So there are two basic drugs under this. One is propyl thiouracil (PTU) and one more is methimazole. So where do this inhibit? They inhibit this thyroid peroxidase enzyme. So you know that this thyroid peroxidase, it was the reason for this for oxidation and for organification, for coupling. This thyroid peroxidase was responsible. So basically whatever happens with iodine and thyroglobulin, this TPO enzyme is responsible. Now inhibition of this TPO enzyme is by these two drugs, that is methimazole and PTU, propyl thiouracil. Okay, so these are our main antithyroid drugs. Now along with this we have one more drug, that is when we give more of iodine, what happens is it will cause release of T4 T3 away from thyroglobulin, that is proteolysis, which means if you give more iodine, then it will cause decreased thyroxine synthesis. So that is known as Volk-Chaikov effect. Okay, so Volk-Chaikov effect says that if there is excess iodine, that iodine will decrease thyroid hormone synthesis. That is the meaning of Wolff-Chaikov effect, and that's why we use iodine similar agent, like iodine similarities like Lugol's iodine. Okay, so that causes decreased thyroxine synthesis. Now third category of drug is which blocks this peripheral conversion of T4 to T3, and that is also done by propyl thiouracil. It has dual action. One is it inhibits TPO also, and it inhibits peripheral conversion also. So this action is unique to PTO, and it is not done by this methimazole. Okay, so these three main antithyroid drugs we are concerned about. So there are some important questions for you, especially when it comes to pregnancy. Okay, so in pregnancy, in first trimester, okay, PTU is preferred. Remember that in pregnancy, first trimester we prefer PTU. But when it comes to first methimazole, okay, methimazole in first trimester has a risk of teratogenicity. It causes aplasia cutis. Now what is aplasia cutis? So for methimazole, we'll avoid in first trimester because it causes aplasia cutis. Aplasia cutis means congenital absence of skin, basically, especially over the scalp and all. Okay, and it has teratogenic risks. It can cause choanal atresia, etc. Okay. Now what happens is during second and third trimester, methimazole becomes the drug of choice. That is because most of the teratogenic, that is congenital anomalies, occur during first trimester. Okay, second and third trimester, there are no congenital anomalies that occur. Okay. Now what about propyl thiouracil? First trimester it is preferred. Second and third trimester it is not preferred because propyl thiouracil has higher risk of hepatotoxicity, liver toxicity. Okay. So if anyone asks you which antithyroid drug to give in which trimester of pregnancy, so it totally depends on which trimester pregnancy the woman is in. Okay. So both crosses placenta, but again propyl thiouracil crosses less. That's why during lactation, PTU is safer compared to methimazole. Now, there is something known as thyroid storm. Okay, so when acute hyperthyroid crisis occurs, that is known as thyroid storm, it can lead to fever, tachycardia, agitation, and here the drug of choice becomes beta blocker or propranolol because it blocks all these symptoms. Okay, it causes adrenergic blockade and also inhibits conversion of active thyroxine, that is T4 to T3 conversion is inhibited by beta blockers. Second is PTU is preferred instead of methimazole. It blocks the synthesis. You remember no, this step. This step you see, it is unique to PTU, that is inhibition of T4 to T3 conversion. So that's why we use propyl thiouracil and not methimazole. This will be exactly your options. Okay. And third is you will use iodine because it will block a release of more thyroxine into the bloodstream by Wolff-Chaikov effect. Okay. Next, Graves' disease. In terms of chronic Graves' disease, okay, in chronic condition, you will use thionamides. For long term, we use something known as radio ablation, okay, radio ablative iodine, where we use iodine 131 isotope, which destroys these tissues which cause increased secretion of thyroid hormones. So this can be used in conditions where there are selective nodules which increase thyroid hormone secretion. So this is contraindicated in pregnancy. So in pregnancy, our drug of choice is PTU and methimazole. methimazole. Okay, and next is surgery. So you should be very careful. Methimazole is not used in first trimester because of teratogenic risk. Second is iodine is given before thionamide, that is before propylthiouracil, when there is worsening of thyroid storm. And third is expect immediate effect. Okay, so you are expecting that it can don't expect immediate effect after you give thionamides, because already there will be some stored hormone. Okay, and this stored hormone will cause action, so it will take some action for it to come into effect. So this point means iodine before thionamide is a wrong thing. That is, you don't give iodine before thionamides. Once thionamide is given, after that you will give iodine in case of thyroid storm. Okay, so first thionamide, that is PTU, and after 1 hour you will give iodine. Okay, so pregnancy first trimester you will give PTU. Okay, so peripheral conversion block, and it is also preferred in thyroid storm. Next, methimazole, it is used for long-term maintenance, morning 1 daily dose. It is more potent and has mild side effects because propylthiouracil is known to cause hepatotoxicity. So thionamide inhibits the synthesis, that is, it blocks thyroxine peroxidase enzyme, and iodine by Wolff-Chaikoff effect, it decreases the iodine thyroxine release. Okay. Next, radioiodine is used in case of some secretory nodules, okay, where thyroxine secretion is increased, and it is contraindicated in lactation and pregnancy, so we don't do thyroid ablation during that time. Okay. So we will go through the questions quickly. Mechanism of what is this? Okay, mechanism of these both is inhibition of thyroid peroxidase enzyme. Okay, thyroid peroxidase enzyme. Next, dash is the additional action of converting T4 to T3 conversion inhibition. Additional action of what? Additional action of yes, very good. It is propylthiouracil. Next, dash is used for symptom control. We use beta blocker for symptom control in thyroid storm. Next, pregnancy drug which is safe in first trimester is propylthiouracil. Next, dash is contraindicated during pregnancy and lactation. Yes, very good. Radioiodine is contraindicated. Okay. Next, do not use dash in the first trimester due to teratogenic risk. Yes, very good. It is methimazole. Okay, so we have covered everything. Next, we'll go to mechanism of action of diuretics. So we are coming to renal part. Okay, now in renals, very important, there are only few drugs which are there. We'll first go through mechanism of all diuretics combined. Okay, so what does diuretic do? Diuretic is basically, it acts on the nephrons, on specific parts of nephron. It causes increased sodium and water excretion. Okay, and it will decrease circulating plasma volume, and it will decrease BP also. So we want drugs which act on proximal tubule. In proximal tubule, we have carbonic anhydrase enzyme in PCT. Okay, so here in PCT we use a drug that is carbonic anhydrase inhibitor, which is nothing but acetazolamide, which inhibits this enzyme carbonic anhydrase, and it will decrease sodium reabsorption. It will also decrease hydrogen secretion. So secretion into the tubule is decreased, so it will cause what? When H plus secretion is decreased, H plus is retained, so it is useful in case of metabolic alkalosis. Okay, metabolic alkalosis, it is useful. Next, second group of drugs is which acts on this thick descending loop of Henle. This thick ascending loop of Henle. Okay, so where is this? This is the thick ascending loop of Henle. Here you have sodium potassium 2 chloride channel blocker. Okay, and this is nothing but loop diuretic, and example for this is furosemide. Okay, furosemide and torsemide. Third category is where they act on this early distal tubule. Okay, DCT. Okay, this is DCT. This is thick ascending loop of Henle. It is almost here. Okay, thick ascending loop of Henle. Now this which acts on DCT acts on sodium chloride channels, and these are nothing but thiazide diuretics. Okay, examples are chlorthalidone, hydrochlorothiazide. Okay, these drugs. Now next is last one is which acts on collecting tubules. So in here this part, okay, collecting tubules, we have drugs which act on ENaC. ENaC means they are sodium channels, basically epithelial sodium channel, E for epithelial. So example for this is amiloride. Okay, amiloride. Next, second is we use potassium sparing diuretic which acts on this distal collecting tubules. It will block aldosterone receptor, and it will not help, it will prevent. What is the action of aldosterone? Aldosterone, this receptors, no, they are present here. Okay, in distal in near collecting tubules. It will help reabsorb sodium, and it will cause excretion of potassium. Okay, So as a result of which sodium will be increased. Okay, this is blocked. Okay, so as a result of which sodium in the blood will decrease, but potassium will increase. Okay, so these actually cause increased potassium, hence it is not increased potassium. Basically they don't allow loss of potassium, hence they are known as potassium sparing. Okay, that's why the name potassium sparing diuretic. Example is spironolactone and eplerenone. Okay, now mannitol is one more drug where it causes like osmosis. It will cause increased water reabsorption, water retention, okay, in the collecting duct. So that is what will be retained here, and it will cause decreased water molecules in the blood vessels. So it will decrease BP, and it will be used in other conditions also. Okay, so these are some of the mechanism of action of diuretics. Okay, so how to remember this? See here, loop diuretics means it is like a loop here. Okay, so sodium, potassium, 2 chloride. Okay, next thiazide is thi and zide. Okay, so basically I don't know how you remember this. Next, potassium sparing is what acts on aldosterone. Okay, aldosterone and ENaC channels, basically we use potassium sparing. And next is mannitol, which causes osmotic gradient. So there are some side effects associated with this. That is, whenever one important thing is whenever you have this pulmonary edema, it is contraindicated in pulmonary edema. The reason is because when we give mannitol via IV, okay, we give IV mannitol, so it causes temporary plasma volume expansion. Okay, blood volume will expand because of because of this osmotic effect. As a result of which, it can worsen pulmonary edema. So mannitol we don't give when pulmonary edema coexists. Okay. Second is a very common side effect of this loop diuretic is ototoxicity. One is ototoxicity, second is nephrotoxicity. Okay, that's why it is not combined. Loop diuretics are not combined along with aminoglycoside, because this aminoglycoside antibiotics like gentamicin, amikacin, they also cause ototoxicity. So never combine loop diuretic along with aminoglycoside. Third is potassium sparing effect. So basically you don't give ACE inhibitors. You know that ACE inhibitors are contraindicated when potassium is more than 6. Okay. In hyperkalemia, they are contraindicated. Along with that, you don't give potassium sparing diuretics because they will interpotentiate the action. Okay, so it can lead to fatal hyperkalemia. So these are the clinical questions that you come across. So basically, when you give loop diuretics, you should monitor especially electrolytes. Electrolytes must be monitored because loop diuretics will cause hypokalemia, and this potassium sparing diuretics will cause hyperkalemia. Okay, even sodium monitors levels also need to be monitored. And one more thing is, whenever you use loop diuretics, make sure that you don't give digitalis altogether, or because even slight decrease in hypokalemia can precipitate digitalis toxicity. Okay, next, what are these rare facts? One is this loop diuretics increases the efficacy. Second is acetazolamide. Okay, acetazolamide, I told you it will cause metabolic acidosis. Okay, so it will cause metabolic acidosis. That is, it is used for metabolic alkalosis because it will cause decreased H plus secretion in the tubules. So as a result of which, H plus is preserved within the bloodstream. So when there is increased H plus, we have when there is increased H plus, basically we have metabolic alkalosis. Okay, sorry, we have metabolic acidosis. So in case of mountaineering, like in altitude, high altitude sickness, what happens is there occurs metabolic alkalosis. Okay, altitude sickness basically causes respiratory alkalosis. Sorry, it is not metabolic alkalosis. It causes respiratory alkalosis. Okay. Because of hyperventilation, basically it causes respiratory alkalosis. So we want to compensate it with mild metabolic acidosis, which will be done by acetazolamide. Okay, so let's solve the questions. So first thing, carbonic anhydrase inhibitor acts on where? It acts on proximal convoluted tubule. Next, loop of Henle inhibits loop diuretics inhibit which channels? Yes, it inhibits sodium, potassium, 2 chloride transporter. Okay. Next, collecting duct osmotic. What is used? We use mannitol. Okay, mannitol is an osmotic diuretic. Dash causes metabolic acidosis and hence is used in high altitude prophylaxis. Yes, very good. What is used? What causes? Yes, acetazolamide. Okay, acetazolamide causes metabolic acidosis. Hence, it counteracts respiratory alkalosis because when there is high altitude sickness, there is hyperventilation leading to respiratory alkalosis. Okay, that is counteracted by acetazolamide. Loop diuretic plus aminoglycoside, if you see in question, always remember ototoxicity and also nephrotoxicity. Okay. Next, drug of choice for acute pulmonary edema is what? Yes, drug of choice for acute pulmonary edema is loop diuretic. Okay. That's why we give, whenever there is acute pulmonary edema, we give what? We give Lasix. Lasix is nothing but furosemide. If aldosterone block, yes, it is potassium sparing diuretic. Okay. Next, diuretics potentiate what toxicity via hypokalemia? Digitalis toxicity. Okay, so next we'll be continuing along with the same topics, because many questions are being asked from these small topics only. Okay, so renal pharmacology is one such topic where if you study less also, you can actually answer more questions. A few important points about loop diuretics. Let's go through the image in detail. So basically the site of action, as told earlier, is thick ascending loop of limb of Henle. Okay, so this is the site of action. Here we have sodium potassium 2 chloride channel blocker. So there shouldn't be any confusion. Loop diuretic means furosemide, means Lasix. All this act at this place only. So now what is their action? Their action is diuresis, which means it will increase excretion of urine. Okay, so there's increased excretion of sodium, potassium, chloride, calcium, everything, because all this like absorption itself, reabsorption itself is inhibited. Okay, so it causes powerful natriuresis, that is more sodium is excreted. Okay, that is not absorbed. Okay, and which are the common agents? Furosemide, torsemide, bumetanide, and ethacrenic acid. I want you to remember these two agents. Okay, common uses for pulmonary edema and for CHF, it will provide rapid relief. Second is this will also increase calcium excretion. You can see here, calcium excretion. So whatever excretion is there, all ions excretion it will increase. So that's why it is used in hypercalcemia also. One risk is ototoxicity with aminoglycosides. Hence, it is not combined along with aminoglycosides. Onset is very fast. IV, it will occur within minutes, and it is contraindicated in whenever there is renal failure or there is low GFR, it is effective in low GFR states also. Okay, next, so what is one thing we should monitor is potassium. Okay, so potassium is need to be monitored. That's why what we'll do is, because loop diuretics decrease potassium, see here, increased excretion of potassium means it will cause hypokalemia, right? So because of that, remember, we'll give it with potassium sparing diuretic, that is for spironolactone and eplerenone. Okay, and avoid with aminoglycosides, I have already told you. Now, hypokalemia can occur with the furosemide overdose. Volume depletion can cause hypotension, and one more thing is it can precipitate hyperuricemia. So gout flare can precipitate along with loop diuretics. Okay. So one more thing is the non-sulfa loop diuretic is ethacrenic acid, and that's why if a patient has sulfa allergy, then ethacrenic acid is the safer alternative. Okay, so loops lose calcium, they lose everything. Okay, hypokalemia, ototoxicity, dehydration, nephritis, allergy, sulfa gout. I think all this I have covered. Okay, so we'll go through the questions. So what is the site of action? Site of action is thick ascending loop of Henle. Okay, there shouldn't be any doubt regarding this. Okay. Second is what is reversible with increased risk with aminoglycosides? It is ototoxicity. Remember, this ototoxicity is reversible. Next, DASH causes arrhythmia with loop diuretics, hypokalemia. Okay, hypokalemia is a dreaded complication. Non-sulfur loop diuretic is ethacrenic acid. Okay. Yes, we'll move on to the next diuretic, that is thiazide diuretics. Thiazide diuretic mechanism of action is on distal convoluted tubule. Okay, so here it blocks a sodium chloride SIM co-transporter. Okay, so when sodium comes inside, chloride goes outside. So as a result of which this is blocked, sodium concentration in blood will decrease. Okay, that is the aim. Okay, as antihypertensive. And second is chloride concentration in the blood will increase. Okay, because chloride is secreted. It was supposed to be secreted out. Okay, so what will happen is there is increased excretion of sodium, increased excretion of chloride, and increased excretion of water. It causes moderate diuresis, not as much as loop diuretic, but will get moderate diuresis and decreased BP. Now, one important thing is where loop diuretics was excreting calcium, here it will reabsorb calcium. So there is calcium retention. Hence, this is used in cases where there is increased hypercalciuria. Okay, whenever there is increased excretion of calcium, we want this because we want to reabsorb calcium. Okay. Now, here also same thing, hyponatremia will be there, hypokalemia will be there. It can precipitate hyperuricemia and it can worsen hyperglycemia and hyperlipidemia. So those with metabolic syndrome, basically this drug is safer to avoid. Next, it is ineffective in renal failure. Loop diuretic we saw it was effective, but this is ineffective when it comes to low GFR. So which are the drugs we have under thiazides? One is hydrochlorothiazide, chlorthalidone. This is metalazone, okay, metalazone, and these are three common agents. Its duration of action is like slower than loop diuretics, and it acts for a longer duration. It is the first line of treatment for hypertension. Okay, I told you A, B, C, D. In that D is diuretic, that is thiazide diuretic. It is used in mild CHF. In severe CHF, we use loop diuretics. It is used in nephrolithiasis, because in nephrolithiasis, what happens? Calcium is excreted into the tubules, and this excess calcium causes kidney stones. No? So what we do is we give a drug which increases calcium reabsorption. So that is thiazide diuretics. Okay, and next we'll monitor for sodium, potassium, and uric acid. Hyperuricemia is precipitated. Okay. If hypokalemia occurs, it can precipitate digoxin toxicity as told earlier, and it should be used cautiously in diabetics because it can precipitate hyperglycemia. Okay. So what all will increase? See here, sodium and potassium only will decrease, rest of the things will increase. Calcium will increase, uric acid will increase, lipids will increase, and glucose will increase. So these are basically calcium catchers. Okay. So which are the calcium catchers? They are nothing but thiazide diuretics. So let's solve questions quickly. Inhibits sodium chloride co-transporter where? In distal convoluted tubule. Next, second, dash is safe in diabetics, neutral metabolic profile. There is one thiazide which is safe, that is indapamide. Okay, indapamide. Remember this. Indapamide is safe in diabetes. Next, dash may cause, thiazides may cause hypokalemia, hyponatremia, and one more metabolic abnormality is hyperuricemia. Okay. Next, first line, and also it causes hypercalcemia. Okay, it causes hypercalcemia. Hence, it is used for hypercalciuria. Next, drug preventing calcium stone is thiazides. Okay. Next, use cautiously in which condition? Diabetes, and also in gout. Gout we don't use thiazides. Okay. Next, we'll go to potassium sparing diuretics. In this image, you can see the mechanism of action is on collecting duct, not distal convoluted tubule. It is collecting duct, the final part. Okay. In late DCT and collecting duct, what happens is here aldosterone. Okay, aldosterone actually acts on these channels. It will cause sodium reabsorption and it will cause potassium secretion. So basically sodium will come into the cell and potassium will go out. But this aldosterone antagonist, that is spironolactone and eplerenone, what it does is it will inhibit this, as a result of which there will be decreased sodium reabsorption and there will be decreased potassium secretion. Since decreased potassium is secreted into the lumen, we have potassium retention. Hence these are known as potassium sparing diuretic. There shouldn't be any confusion. Now second is aldosterone also increases this ENaC. ENaC means epithelial sodium channel, because aldosterone's primary function is to retain body volume, okay, fluid volume. So what it will do, it will cause direct insertion of this ENaC channels, that is sodium channel, and it will cause direct absorption of sodium. Now this is inhibited by amiloride. Okay, amiloride is inhibiting this ENaC channels, and hence through this also amiloride and triamterene. Okay, so these both will cause again ENaC inhibitors. Now where are these drugs used? Potassium sparing. One is in CHF along with loop diuretics. Second is in Conn syndrome, because in Conn syndrome where we have hyperaldosteronism, these drugs exactly act at high aldosterone receptor, right? So that's why it is used in Conn syndrome. Third is in resistant hypertension. Okay, in resistant hypertension we use, and fourth is in cirrhosis we use spironolactone, because there also we use loop diuretic or loop diuretics to decrease fluid retention. That's why we use along with that potassium sparing agent. So loop thiazides will cause potassium loss, and this potassium sparing will cause potassium retention, and hence there is a balance of potassium. Okay. Next, eplerenone is used in CHF post MI because it has got post MI benefit. You can just remember this as one word. Okay. Next, which when there is potassium sparing diuretic, don't combine ACE inhibitors and ARB because it can cause severe hyperkalemia. Second is spironolactone. It is also known to cause gynecomastia and menstrual irregularity. This is a side effect of potassium sparing diuretic, that is spironolactone. So spironolactone causes gynecomastia. You will have to remember it. Third is in renal failure, we'll have to avoid this, because in renal failure there is risk of hyperkalemia, because the kidney is not able to excrete potassium. So in this case also we'll be not using potassium sparing, because it can aggravate hyperkalemia. So one drug which we can use to some extent in renal failure is loop diuretic, okay, that is furosemide. Next, what are the other rare facts? See, eplerenone is more selective for aldosterone, hence it has fewer endocrine effects, okay. Second is amiloride, which is ENaC channel inhibitor. It is not only useful in above condition, it is also useful in one more condition, that is lithium induced diabetes insipidus. So which condition? In lithium induced, when we'll be studying lithium, no, I'll be going through this diabetes insipidus. In that condition, amiloride is useful, okay. One more use of spironolactone is it is used in PCOS and hirsutism also, okay. Next, you have to monitor potassium and renal function when you give this, okay. I think rest all things I have covered, okay. We'll go to the questions. So yes, DASH is more selective and fewer endocrine effects. Yes, very good. It is eplerenone, okay. Eplerenone, not spironolactone. DASH is also used in PCOS and hirsutism. Spironolactone. So spironolactone is used in PCOS and hirsutism. Avoid with AC inhibitors and AR base. What you have to avoid? You have to avoid this potassium sparing diuretic, because risk of severe hyperkalemia and not hypokalemia. Drug of choice for lithium induced DI is amiloride. Remember, it is amiloride. Yes, very good. So we have finished potassium sparing diuretics. Next we'll go to GIT. In GIT we'll be going through mainly antacids and secretory agents, antimotility agents. Okay, so in GIT we have very few questions which are asked in pharmacology as such. So basically GI agents actually target either acid production, or they affect motility of the gut, or they increase or decrease secretions, okay. So we'll see some antacids. So antacids, they basically decrease pH, okay. So hence they neutralize. So they increase pH and hence they neutralize, okay. So these are basically just symptom relievers, okay. So they just work according to pH based, okay. Second are H2 blockers. So these are competitive antagonists. These are H2 means histamine, okay. So this H2 receptor, it will cause increased CAMP, and it will cause increased H plus production, that is acid production will increase, okay. So basically this H2 blockers will cause competitive antagonism, and hence pH will increase, okay, that is H plus production will decrease. Third is proton pump inhibitor. These are irreversible inhibitors, okay. So what these do is they act on this potassium and H plus potassium ATPase, okay. This is the pump which actually sends H plus inside and potassium outside, okay, in the gastric acid secreting cells, okay. So as a result of which there is a decreased H plus secretion in the stomach, as a result of which there is improvement in the symptoms. So most potent acid suppression is by PPI. So PPI is the drug of choice for gastritis and whatever, okay, all those peptic ulcer disease complex, everything will come under that. Second is prokinetics. So what are prokinetics? Prokinetics mean they will increase gastric emptying, okay. So gastric emptying into the intestine will increase. So these are the ones which increase gastric emptying, and the mechanism is by D2 blockade, okay, that is in the brain, and one more is 5-HT4 agonism. These are serotonin receptors, okay. So these two mechanisms are involved in gastric emptying. So D2 blockade and 5-HT4 agonism, not antagonism, okay. Next is antiemetics, which are basically which act on D receptors, okay, dopamine receptor, serotonin receptor, and muscarinic and H1 receptor. You don't want to go in detail. Laxatives can be osmotic laxatives, or they can be there are various types of laxatives also, okay, other type. Here we have mainly considered about osmotic laxatives which cause stimulant induced motility. And next are antidiarrheals which decrease peristalsis. So best example is this mu receptor inhibition, loperamide. So that causes decreased peristalsis and causes symptomatic relief, okay. So to remember things, H plus potassium is PPI, which is permanent pump inhibitor, remember like that, okay. Next is H2 blockers which cause histamine, which causes halting of H plus secretion. Third is metoclopramide, which is a prokinetic which acts on D2 like antagonism and 5-HT4 agonism. And last are antacids which neutralize whatever acid production happens. Now, you shouldn't give antidiarrheals in bloody diarrhea. This is a very This is a very dreaded complication. It can increase infection risk also. Second, PPIs, don't combine it with clopidogrel, and in this PPI, the main is omeprazole. Okay, omeprazole don't combine with clopidogrel. So basically, the clinical scenario will be a patient with stroke who is on clopidogrel since last few months came to you with gastritis or peptic ulcer disease. So what is the next? What is the problem with this? Okay, so basically it inhibits CYP2C19 and hence it causes decreased efficacy of clopidogrel and hence there is increased risk of stroke if you give omeprazole along with it. Next, long-term PPI can also cause fractures. It can also decrease magnesium. Okay, this decreased magnesium is a reason for this hypocalcemia causing fractures. Okay. Next, PPIs are given before meals. I think everyone knows it by now. H2 blockers are given at night. Okay. What is the example for this H2 blocker? Yes, cimetidine, ranitidine. Okay, so cimetidine, ranitidine are the H2 blockers. Okay. What are PPIs? PPIs are pantoprazole, omeprazole, esomeprazole, rapiprazole, all those things. Okay. Now, antacids can cause drug interaction and hence you should avoid it with the tetracycline fluoroquinolones because these drugs require an acidic environment to get absorbed, but antacids will cause less acidic environment, that it will go towards alkaline environment. Okay. Next, so PPI acidic activation is required and cisapride is withdrawn. So cisapride was cisapride is a prokinetic drug which was actually withdrawn for QT prolongation. I don't think that question will be asked now. Drug of choice for GERD is PPI, no doubt in that. Drug of choice for motion sickness is not some antiemetic. It is basically scopolamine, which is known as hyoscine. Okay, one more is meclizine. Okay, meclizine is also used for seasickness. Okay, seasickness. I think I told about this in ANS module. Next, metoclopramide acts via D2 blockade and hence metoclopramide also can cause Parkinson-like symptom because it is causing D2 blockade. Okay, so we'll solve questions. Proton pump inhibitors irreversibly inhibit which? H plus potassium ATPase pump. Next, prokinetics acts via what blockade? D2 blockade. Okay, and 5-HT4 agonism. Drug of choice for GERD is PPI. Drug of choice for motion sickness is scopolamine or hyoscine. Okay. Next, mechanism of metoclopramide is D2 blockade plus 5-HT4 agonism. Okay. So GIT is not much frequently asked. Okay, we'll just go through one drug from which questions can come. That is metoclopramide. Because of its D2 receptor blockade, we'll have some symptoms. Okay, so basically metoclopramide acts on two mechanisms: D2 blockade in chemoreceptor triggered zone and 5-HT4 agonism in the bowels. It will be acting. Okay. So what will happen is this D2 is blocked and 5-HT4 is activated. That is a mechanism of action. As a result of which in GIT there will be increased lower esophageal sphincter tone. So this is the lower esophageal sphincter. So that tone is increased. That is, it will get tightened and it will increase gastric emptying time also and it will prevent reflux. Okay. So these three mechanisms it will act. Now this D2 receptor which is involved in chemoreceptor trigger zone. Okay. That will be blocked. Okay. Hence chemoreceptor trigger zone is not activated and hence it is used as an antiemetic because of this dopamine action. Okay, because of this dopamine blockade it will cause decreased nausea and vomiting because chemoreceptor trigger zone is the center for vomiting. Okay, that's why it is an antiemetic. Now indications are GERD, gastroparesis, vomiting, antiemetic, everything. Now what will happen is, most important is, your question will be based on this. A patient was given metoclopramide. After a few days he developed having dystonia, tardive dyskinesia. The patient had galactorrhea, that is increased milk secretion. Okay, from like even it can occur in males or females, and there were some extrapyramidal symptoms like tremors and all. So these are because of blood-brain barrier crossing effect and blocking the dopamine receptors in the brain. Okay, so that's why this is avoided in Parkinsonism and it is avoided to be used in caution with seizure disorder also. The second thing is whenever you are giving prokinetic which will increase bowel movement, it should be avoided in obstruction, because if you are giving something which increases motility in intestinal obstruction, it will aggravate intestinal obstruction. Okay, there is risk for intestinal perforation and rupture. Okay, that's why we will not give D2 blockers, that is metoclopramide, in GI obstruction. We will not give any prokinetic drugs in GIT obstruction. Okay, I think I have cleared everything. So we'll just answer a few questions. That is, crosses blood-brain barrier, causes extrapyramidal side effects. Okay, increases what via D2 blockade? It will increase prolactin, via D2 blockade. So you know that dopamine inhibits prolactin, okay, and prolactin increase causes galactoria, okay. So what will happen is when we give D2 blockade, there is no one to inhibit prolactin, hence prolactin increases further and it leads to galactoria. It can also lead to infertility, okay, because increased prolactin will interfere with pituitary hormones. Second is avoid with dash, that is avoid in Parkinsonism, okay. Parkinsonism you have to avoid. So next we'll go to antibiotics, and first antibiotic is metronidazole. Next, metronidazole, basically it comes under a group of nitroimidazole. So you don't have to remember it, but you have to remember that it is used for anaerobes, okay, nothing else. For anaerobes it is used. So metronidazole is basically used for anaerobic infection, and other metronidazole congeners like tinidazole, ornidazole, all those are mainly related to anaerobic. So to cause anaerobic cytotoxicity, you need to generate some free radicals. So basically what happens is, so this is anaerobic bacteria, okay, and here what happens is this metronidazole, which is a prodrug, which it enters into the cell, okay, it will be broken down by this nitroreductase enzyme, okay, which are specific for anaerobes only, hence it doesn't act for aerobes, okay. So for anaerobic bacteria, this metronidazole acts is broken down by nitroreductase to produce some toxic radicals, and these will lead to DNA strand breakage and cell death. That is the basic rule why it only acts on anaerobes. So which are the anaerobes which it is active against? So one is Bacteroides fragilis, Clostridium difficile, and Fusobacterium. So these three you remember. I think again we'll be repeating this in micro, and it is very effective against three very important protozoa. That is, one is Giardiasis, second is Entamoeba histolytica, and third is Trichomonas vaginalis. I am very sure in NEET PG if a question is asked, it won't be based on these bacteria, it will be based on these three protozoa, okay. So what are its clinical implications? One is it is used in anaerobic infections, amoebiasis, it is used in trichomoniasis, and it is used for pseudomembranous colitis. This is one off-label use, okay. Next, what are the routes? We can give by oral, IV, topical, whatever, okay. Next, what are the fatal traps? Okay, so there is something known as disulfiram reaction. So this we had seen before also with some other drugs, okay. So whenever you use this drug along with alcohol, it will cause disulfiram like reaction. It can cause vomiting, vasodilation features, flushing and all, okay. So this is one question where one of the option will be metronidazole when question is asked on disulfiram reaction. Second is metronidazole. M is for metallic taste. So particular metallic taste is associated with metronidazole. And third is it should be avoided in first trimester of pregnancy. I think you don't have to remember this point, but let it be at the back of your head. Next, you have to monitor what if you're giving for a longer duration, especially in anaerobic infections such as some abscess, okay. In that all we'll give long-term metronidazole. That time we'll be we'll be monitoring LFTs, okay. And second is we'll be also using this in H. pylori regimen, okay. So basically for H. pylori regimen, in triple regimen, we'll be using this metronidazole along with the amoxicillin, and we'll be using a PPI like pantoprazole, okay. So this is the triple regimen we use for H. pylori infection. And again, you have to avoid alcohol because of this disulfiram reaction, okay. Everything else I think I have explained. Okay, one more thing is this alcohol intolerance, this disulfiram reaction is because of aldehyde dehydrogenase inhibition, okay. Okay, fine. So I think everything is explained. Let's go to the questions. What is the spectrum? Anaerobes and protozoa. So basically it is anaerobic bacteria, and along with that what do you have? You have three protozoa. Which are those? Yes, very good. Amoebiasis, okay, Entamoeba histolytica. Second is Giardiasis, and third is Trichomonas, okay, Trichomonas vaginalis. Next, second, crosses blood-brain barrier, hence it is useful to treat brain abscess. Remember, brain abscess, we'll be using metronidazole also. Not only metronidazole, we'll be using metronidazole along with combination with other antibiotics. So dash reaction with alcohol, it causes disulfiram reaction, okay. Next, drug of choice for pseudomembranous colitis caused by cause of anaerobes is what? It is metronidazole. So now you will ask me for drug of choice for pseudomembranous colitis, how can it be metronidazole? We read it as oral vancomycin. Yes, you are right. It is oral vancomycin. But before oral vancomycin, in older days, we were using metronidazole. Okay, so this is earlier drug of choice. Okay, not now. Okay, so this correction you'll have to make. Next, avoid alcohol during and how much? 48 hours post therapy. Okay. Next, we'll go to drugs causing disulfiram like reaction. Again, I think there is an image for this. So what is this disulfiram reaction? And a question will definitely come in pharma from this topic. Okay. So basically what happens is ethanol in our body is I'll just change the color to a lighter color or else you won't be able to watch it. Okay. So ethanol basically is metabolized in the body by alcohol dehydrogenase enzyme to acetaldehyde. Okay. And this acetaldehyde is a toxic intermediate. So if this acetaldehyde builds up, okay, it can cause symptoms such as flushing, headache and vomiting. Okay, so this triad of flushing, headache and vomiting constitutes a classic triad of disulfiram reaction. So what happens is when there are disulfiram reaction producing drugs, okay, so what they do is they block this aldehyde dehydrogenase, because whenever this acetaldehyde builds up, this aldehyde dehydrogenase, this is alcohol dehydrogenase and this is aldehyde dehydrogenase. So this aldehyde dehydrogenase will break down acetaldehyde. So these disulfiram like drugs, no, they will block this aldehyde dehydrogenase and hence acetaldehyde concentration will increase whenever alcohol is taken. Okay, so that's why they will land up in these symptoms. Okay, so there could be some hidden alcohol sources also, like for example in mouthwash, in cough syrup, okay, or some alternative medicine. There also alcohol concentration is maybe there, and along with that, when they take disulfiram producing drugs, these drugs are basically metronidazole, tinidazole, cefoperazone, cefotetan and grisofulvin. How do you remember this? See here, MCG. Okay, so M is metronidazole, cephalosporins, that is cefoperazone and cefotetan, and then you have grisofulvin. So when you have metronidazole, you'll automatically you will remember tinidazole also. Okay, yes. So these antimicrobials, okay, and anti-diabetic and some antiprotozoal also cause. For example, antimicrobial, that is actually metronidazole only. Okay, this is metronidazole. Okay. Anti-diabetic, that is chlorpropamide is basically sulfonylurea. Okay, just like you have sulfonylurea like glabin, clement, glimepiride. Similarly, you have chlorpropamide, which was the first generation earlier. Okay, so this is not useful for us to remember. And nifurtimox is also not important for us. What is important? These 5 drugs. Okay, metronidazole, tinidazole, grisofulvin, and 2 antibiotics, that is cefotetan and cefoperazone. Okay, these are the 5 antibiotics that we'll remember. Okay, rest all I think I have explained already, so we'll go to the questions. Okay, there are no questions, only one question. Yes, metronidazole, tinidazole. Okay, then we have cefotetan, then cefoperazone, okay, which is a cephalosporin. Okay, rest chlorpropamide, okay, nifurtimox. And what is the mechanism? Okay, everything I have explained, and up to 24 hours the reaction might persist. Okay, rest all things you can read from this. Okay, next, which are the drugs causing photosensitivity? Again is an important question. Yes, we have mnemonic for this also. So basically what happens is because of drug-induced phototoxicity or photoallergic effect, okay, these 2 effects are there. You don't have to remember that. There is exaggerated UV based skin reaction. Okay, so basically your MCQ point will be rash on sun exposure while on drug therapy. Okay, this is the exact sentence that will be asked in your MCQs. So which are the drugs? See, one is tetracycline, doxycycline, you will have to remember, fluoroquinolones. Okay, then you have NSAIDs, that is piroxicam and ritoprofen. Ritoprofen is nothing but ketoprofen. Okay, it is a brand name. Next, amiodarone. Okay, and isotretinoin and diuretics. So out of this, if you ask me which are important, remember one is tetracycline, fluoroquinolones. Fluoroquinolones means ciprofloxacin and all these floxacins, ofloxacin, moxifloxacin, all those are fluoroquinolones. Remember NSAID is amiodarone. These are more than enough. Okay. So what do they cause? They cause phototoxic DNA damage, allergy, blue-green pigmentation is caused by amiodarone. Just remember this, amiodarone, which is an anti-arrhythmic, causes blue-green skin pigmentation. Okay, rest of the things you don't have to remember. Okay, yes. Next important point in this is sunscreen doesn't prevent all phototoxic effect. Okay, this can be like all or none type of questions which are asked in INICET. Not all rashes is allergy, UV exposure is required. Okay, and both implicated double check HCS. Okay, so just read these things. Okay, so advise sun protection, stop offending drug, and use topical steroid. This is the treatment you give. And then I think rest all things are already covered. So we'll just go through the questions, whichever is important. Okay, so tetracyclines, fluoroquinolones, and one more group of drugs, that is sulfonamides. Okay, sulfonamides. And in sulfonamide, you have one important drug, that is sulfamethoxazole, which comes as cotrimoxazole. Okay. Next, antiarrhythmics, you have amiodarone. Next, you have antibiotic causing phototoxicity, which is antibiotic. Yes, you have fluoroquinolones. Okay, one specific antibiotic, if you want to write, it is doxycycline. One antibiotic which causes extremely important is doxycycline. Okay. If photoallergic NSAIDs, which is a photoallergic NSAID, it is piroxicam. Okay. Rest of the things I think I have explained already. Okay. Next, we'll go to next endocrine part, that is insulin. So yes. So what happens is from pancreas, insulin is secreted. Insulin will act on this tyrosine kinase receptor. Okay. And then it will cause this GLUT4 receptors to go to the cell surface, and from this glucose will come inside. Okay, so this is basic how insulin secretion and action takes place. So the main important transporter here is GLUT4, which should come from the cytoplasm to the cell surface. Only then glucose can come inside the cell. Okay, now what happens is insulin is an anabolic hormone, which means it will help build weight. Okay, like for example, it will help synthesis glycogen. It will help store fat, and it will help build protein. It will stop what? It will stop glycogenolysis, gluconeogenesis, lipolysis. So these are the functions of anti-insulinic. These are mainly by the counter-regulatory hormones like glucagon-like action. Okay, so glucagon has these following below actions. Now, insulin preparations can be different based on the duration of onset and their duration of effect. So one is rapidly acting insulin. So you have Lispro, Aspart, and Glulicin. So this rapidly acting insulin you will give along with the meal only, because it will act within like few minutes. Okay, so you don't have to give it like 30-40 minutes before. Short acting insulin like regular insulin, which is used in DKA. Remember, this question will definitely come. Which insulin is used in DKA, diabetic ketoacidosis? We use regular insulin. And this regular insulin is given some 30 minutes before the food. Okay, because it has to take some time for action. Okay. Second is, if you want 2 peaks in a day, and if you want a small, like you want a duration of action to be intermediate, then you have NPH insulin. Okay. And then if you want a long acting, which you can give at night as a basal, this one, and then you can give something like a bolus. Then for basal insulin, you will give long acting insulin. These are glargine, detamir, and deglutec. Okay. So there shouldn't be any confusion regarding this. Okay. So you have mnemonics to remember this also. Rapid means Lispro, lag. Okay. Lispro, Aspart, and Glulicin. And then on log you have long acting, you have glargine. Okay. This is the longest, and deglutec also. Okay. And then mechanism of insulin action is via tyrosine kinase inhibitor receptors. Okay. Now, what is the most common side effect of insulin is hypoglycemia. Most dangerous also and most common also. Now remember, don't mix anything with glargine. This glargine comes with a warning also. Glargine is the most commonly used long-acting insulin to be given at night. We usually give at 10 p.m. and along with it we give 3 bolus doses before meal, just before meal. Okay. So this glargine should not be mixed with other insulin because it can cause precipitation. Precipitation means it will stay in the syringe only. It won't go into the system. Okay, it won't be in suspended form. Next, it is inhaled. Okay, so what it means by inhaled insulin is there is actually a new insulin which has come, which can be taken through nasal route, intranasal route. It is known as Afrezza. Okay, Afrezza is the name of the formulation. And it is contraindicated in smokers and asthma because it can precipitate bronchoconstriction. Okay, and this important thing we have discussed in ANS also, that beta blockers mask hypoglycemia, that is sympathetic symptoms, and that's why beta blockers should be given with caution, with prior notice to the patient that you can have hypoglycemia and still your symptoms can be masked. Okay, next. So one important thing is you will have to rotate insulin site. When you're giving an arm, then you should give to the other arm or your abdomen. Okay, so you have to rotate. Otherwise, what it will cause? It will cause lipodystrophy. It will affect the fat composition around the subcutaneous tissue. Okay. Second is whenever the patient lands in DKA. Okay, whenever you are giving IV insulin, make sure that what insulin does is it causes transcellular shift of potassium, which means it will put whatever potassium is there in the blood vessel, no, it will make it go into the cell. Okay, so potassium is taken into the cell when insulin is given, as a result of which there can be hypokalemia. That's why you should always look for potassium values, and you should add potassium if needed when you are giving IV insulin in DKA. Next, glargine is peakless because it is long acting, so there is no peak. It will go like a basal. Okay, then you will have 3 peaks like this for a bolus regimen. Okay, this is the basal and this is the bolus. Okay, and ultra long acting is the longest acting is deglutec. Okay, there shouldn't be any confusion regarding insulin. It's a very important question from OBG, pediatrics, from medicine and pharmac. Okay, so activates tyrosine kinase receptor, increases GLUT4. Okay, GLUT4 is the main glucose transporter. Preparations: lispro, aspart and glolicin are rapid acting. Okay, or we'll say ultra short acting insulin. Okay, next. Glargine is peakless. Dash is equal to ultra long acting deglutec. Deglutec is the ultra long acting. Dash mask hypoglycemia symptoms, beta blockers. Rotate injection sites to prevent lipodystrophy. Yes, I think that's it. We'll go to next topic, that is oral anti-diabetic drugs. So basically what happens is in type 2 diabetes mellitus, insulin, basically the pancreas goes into hyperinsulinic state because of increased insulin resistance. So insulin receptors are not responding to whatever insulin is doing. GLUT4 receptors are not coming up at all. So even though there is insulin increase in the blood, still glucose is not utilized by the muscles and other tissues. As a result of which body has to secrete more insulin and pancreas goes into burnout stage. Okay, so that's why this liver, muscle, adipose tissue, everything will be affected. Last to affect is liver, but first to affect is like muscles, adipose tissue and all. Okay. Next, now oral antibiotic drug, what it will do is it will slowly it will act through various mechanisms to increase insulin secretion whatever is there in the pancreas. Okay. Now, this oral anti-diabetics will lower glucose levels. It can cause hypoglycemia. It can alter weight changes also, and it can differ in adverse effects with respect to different organs. Okay. Now, we'll go through different classes of oral anti-diabetic drugs. Okay, anti-hypoglycemic agents, oral hypoglycemic agents. Okay. So here first we have insulin secretagogues, which means it will increase the secretion of insulin from the pancreas. So how much ever pending part of pancreas is there which is unaffected, from that it will increase insulin secretion. So there are two classes of drugs here. One is sulfonylurea. The common names are glibenclamide and glimepiride, and one more is meglitinides. Okay. Second is a biguanides, and best example for this metformin. Okay, metformin is used right, left and center. So there are two main effects of metformin which you should know. One is lactic acidosis, which it can cause. Second is it can cause GI upset, and third is vitamin B12 deficiency is also linked to metformin. Okay. Third is this meglitinides, which I told you, that example for meglitinide is repaglinide. Not many questions are asked, but if any tough question is asked, they may ask like which is an example of meglitinide. Okay. Next, third class of drugs is thiazolidinones. So example of this is pioglitazone. Now there are side effects of this, that is it can cause edema, it can cause weight gain because of edema only, and it can cause fractures also. So pioglitazone is one more like a third class of oral hypoglycemic agents. And fourth is alpha glucosidase inhibitors. Basically what happens is these don't allow to absorb glucose from the intestine only. Okay, so as a result of which glucose will stay in the intestine, it will be fermented by the bacteria there, and it will lead to flatulence, diarrhea and all. And example for this is acarbose. There is fifth group of drug, very important, very rampantly used nowadays, that is SGLT2 inhibitors. Now what this SGLT2 does is, SGLT2 is sodium glucose transporter 2, which is present in the kidney. Okay, so what it does, it causes glucose reabsorption. So by blocking this will cause it will inhibit glucose reabsorption. So there will be decreased glucose in the blood and more will be excreted through the kidneys. A side effect of this is UTI, because more glucose is going in the blood, no? So that's why in the urine, so that's why it can precipitate growth of bacteria. Second is it can also cause dehydration. Third is it can cause euglycemic ketoacidosis, which means glucose levels will remain normal only, but still there will be ketone bodies in the blood. Okay, so that drug is SGLT2 inhibitors. Example is dapagliflozin. Other examples are empagliflozin. Okay, next. See, metformin can be used in renal and hepatic failure. Okay, and second is sulfonylureas will cause prolonged hypoglycemia. Hence, prolonged use can cause hypoglycemia. Hence, it should be used cautiously in adults. Third is pioglitazone is contraindicated in CHF because it will cause edema, right? It will cause fluid retentions, which is bad for CHF. Okay, that is congestive heart failure. Next, pioglitazone rarely has been associated with bladder cancer. Okay, these are like rare ionicity facts. SGLT2 can cause increased levels of LDL. DPP4, now these are new set of drugs, DPP4. So I'll explain this in now itself. So examples for this DPP4 are the gliptins, which are sitagliptin, okay, vildagliptin, saxagliptin, linagliptin. Okay, so gliptins. So what does this gliptins do is they inhibit this enzyme DPP4. So what is DPP4? DPP4 is an enzyme which is involved in the metabolism of GLP. GLP is increasingly discussed nowadays because of Ozempic. Okay, you might remember Ozempic drug, which actually increases GLP levels. So GLP is like gastric inhibitory peptide and glucagon-like peptide, okay, and gastric inhibitory peptide. So DPP actually inhibits this, and we have drugs which inhibit DPP, as a result of which GLP will increase, and there will be decreased insulin resistance. There will be decreased increased glycogenolysis, decreased increased lipolysis. All those effects will come from this. Okay, so I think I have explained everything. We'll go through the questions quickly. So meglitinides, rapaglinide is an example. Biguanides, okay, so which is example? Metformin. Okay, metformin, it will cause lactic acidosis, GI upset, and vitamin B12 deficiency. Dash in okay, we have one more. Triglycerides are contraindicated in CHF because it will cause edema. Next, alpha glucosidase, what is the example? Acarbose. Next, dash inhibitors cause all these things. Yes, we discussed. SGLT2 inhibitors, examples are gliflozins. Okay, this is gliflozins. DPP4 inhibitors are gliptins. Okay, gliptins. Next, okay, there is one more important thing which I forgot to mention, that sitagliptin is associated with nasopharyngitis and mild GI side effects. Okay, pioglitazone rarely is associated with blood cancer. SGLT2 can paradoxically increase LDL levels. Okay, next, weight neutral agent, which is the weight neutral agent among all this? Sulfonylurea. Okay, sorry, SGLT2 inhibitors. Am I right? Yes, SGLT2 inhibitors are weight neutral. Okay, next, sorry, weight neutral agents are DPP4. Sorry, DPP4. Okay, there's one more MCQ trigger, hypoglycemia plus weight gain. This is sulfonylurea. Sulfonylurea causes weight gain. Okay. Okay, next, quickly through one more drug, that is metformin. Next topic is metformin. So metformin basic mechanism of action will be it's a biguanide basically. Okay, so it will activate AMP kinase. Okay, this enzyme AMP kinase, which in turn stimulates hepatic gluconeogenesis, decreases hepatic gluconeogenesis. So as a result of which glucose production is decreased. Second is it increases insulin sensitivity and increases peripheral glucose uptake. So basically what happens in type 2 diabetes mellitus because of insulin resistance, that is counteracted by metformin, and hence metformin becomes a wonderful drug. Final effect is there is normoglycemia, but there is no hypoglycemia, unlike sulfonylureas, which can cause profound hypoglycemia. Okay, so if in exam they will be asking what is the mechanism of action of metformin, it will be activation of AMP kinase. Okay, so there shouldn't be any confusion. So in addition to type 2 diabetes mellitus being first line, there are other uses also. One is it is weight neutral, so and it can cause mild weight loss also. So it is used in obese people also along with diabetes. Second is it has cardioprotective action because it decreases macrovascular risk by decreasing triglycerides. Okay, so it has cardioprotective action. Third is the benefit in PCOS. Hence, what happens in PCOS? If you had watched my pharmac video, you would have known that there is insulin resistance. Okay, so this insulin resistance is counteracted by metformin, and hence metformin is also used in PCOS, and it reduces fatty liver changes also. So all the things related to metabolic syndrome are counteracted by metformin. One rare side effect, but fatal side effect, is lactic acidosis. Okay, lactic acidosis is a main side effect of metformin, and second is in hepatic and renal failure there is risk, so we will have to decrease the dose. Next, what are the contraindications? Renal and hepatic failure. Next, in sepsis, MI, etc. And in contrast studies, you will have to stop 48 hours before doing contrast studies. You will have to stop metformin. Okay, so these are like rare things that can be asked in INICET. Common side effects, if they are asked, okay, lactic acidosis is a very rare side effect. Common side effect will be GI upset. It can cause diarrhea, nausea. That's why we start with a lower dose and then we increase the dose. One more side effect is it can alter vitamin B12 levels. Hence, renal function and B12 levels are to be monitored on yearly basis. Okay, so you can continue metformin lifelong. There is no, it's a very wonderful drug which has minimal side effects. So there is no much complications also regarding this. I think I have discussed everything. Yes, you can go through this. Okay, we'll just go through the questions now. Activates what? Activates AMP kinase. Okay, as a result of which there is decreased gluconeogenesis and increased insulin sensitivity. So what is the site of action? It acts on both liver and skeletal muscles. So both it acts. Okay, in liver it decreases hepatic glucose output, that is decreases gluconeogenesis, and in skeletal muscles it increases peripheral glucose uptake. Okay, so there is no risk of hypoglycemia. Next, improves DASH via insulin sensitization. Improves, yes, it improves the symptoms of PCOS. Okay, next, first line drug for type 2 diabetes mellitus. There is no doubt regarding this. It's metformin. Contraindicated in DASH, metformin. Yes, it's contraindicated in renal failure. Okay, renal failure mainly. Next, monitor renal function and which levels? Vitamin B12 levels. Okay, so these things you will have to remember. Next, we'll go to second class of drugs, that is SGLT2 inhibitor. So SGLT is sodium glucose co-transporter 2. Okay, so this is present in the proximal convoluted tubule. So what its action is? Its action is to increase glucose excretion. So we'll see in depth. See here. So this is the proximal convoluted tubule. So here you will find this SGLT2 receptor. So what it does is glucose will be filtered in the glomerulus and it will enter the nephron, right? So it will enter the proximal convoluted tubule. So this SGLT2 will cause reabsorption of this glucose, and this is prevented by SGLT2 inhibitors. So there is decreased renal glucose reabsorption, as a result of which glucose is excreted in the urine, and there is increased urinary glucose excretion that causes decreased plasma glucose. Okay, so there shouldn't be any doubt regarding this. So which are the agents we have? We have gliflozins. Okay, dapagliflozin, empagliflozin, canagliflozin. They have an effect on weight also. These SGLT2 inhibitors, they'll decrease weight and they'll decrease BP also. So it has multifactorial benefit, and they are cardio and renal protective also. Okay, so most renal protective among this is it's empagliflozin. Okay, so remember, this can be asked as a question, which has most cardioprotective and renal protection action among the gliptins. Among the gliflozins, that is SGLT2 inhibitor, that is nothing but empagliflozin. Okay. Next, it improves heart failure, promotes ketone utilization, all this, and it also causes mild osmotic diuresis because glucose is osmotic molecule. Now, what is the side effect of having this SGLT2 inhibitor? There's two important risk factors. One is UTI risk. This is because glucose is excreted in the urine, so that provides a safe ground for bacteria to grow. Okay, so that's why chances of UTI is higher. And second is euglycemic ketoacidosis, where ketone bodies are present in the urine, but still there is no hyperglycemia. Okay, so this is known as euglycemic ketoacidosis. The drug which causes this are SGLT2 inhibitors. This can be very well asked in your exams. So you will avoid this in renal failure because of its decreased efficacy, and you will be discontinuing this before surgery, fasting, etc. Okay, so all these things I don't think it is that useful. Okay, so you can just go through this. Okay, we'll go through the questions now. Okay, I think I have explained everything under this. Yes, so mechanism is inhibits SGLT2 transporter in proximal convoluted tubule. Okay, there shouldn't be any confusion regarding this. Dash improves heart failure. I told you, cardiovascular and renal protection. Which drug? Yes, empagliflozin. Next, DASH infections will have UTI infections as a side effect. Risk of which ketoacidosis? Euglycemic ketoacidosis. Oral antibiotic drug reducing cardiovascular mortality is empagliflozin. Okay, empagliflozin. Okay, so shall we move on to next topic? Yes, very good. Yes, we'll move on to next topic, that is oxytocin. Okay, so oxytocin is a hormone which is secreted by the posterior part of the pituitary, which acts on this GQ, okay, GQ coupled receptor, okay. Basically, it is GQCR. It acts on the uterine smooth muscles, okay. It acts on the uterine smooth muscles, and then it increases IP3-DHG. So it acts via IP3-DHG pathway. It increases release of intracellular calcium, and then it causes uterine contraction. So one important question that can be asked from this is, it acts via which pathway? It is IP3-DHG, because in hormones, knowing pathways is very important. We'll be covering this in physiology also. So what are the functions of this oxytocin, or what are the uses? One is for contraction of uterus during labor, and second is for milk ejection reflex. Okay, so milk ejection is done by oxytocin. Milk secretion is by prolactin. Next, what are the uses? One is induction of labor, second is postpartum hemorrhage, and third is milk letdown. Okay, all these three are uses of oxytocin. So oxytocin we can give via IV route, where we use in labor, and second is IM route, and third is via nasal route also for lactation promotion. Okay, so which are the types of oxytocin? Synthetic oxytocin. One is carbetocin. Okay, it is a long acting and it is used for PPH. Okay, so carbetoxin is used in C section. You can remember as C for C. And next is demoxytocin. So this is a oxytocin that can be given by buccal route. Okay, so this can be asked in your INICET, because this is a recent update, can be asked in NEET also. This is a recent question that can be asked. Okay, demoxytocin. So you should know that one is excessive dose. If you give excessive dose, there can be excessive contractions, which can actually lead to uterine rupture. So this is a complication. Second is it is contracted in cephalopelvic disproportion, because pelvic cavity can't expel the fetus. Okay, because there is no room enough for expulsion of fetus. So what happens if you give more contractions? That can lead to detrimental effects. Next, third is water intoxication. Okay, why water intoxication occurs is because oxytocin has similar actions of ADH. Okay, so ADH has property of antidiuresis. That means it will try to retain water. Okay, so that's why that effect will be pronounced. So that's why we'll have water intoxication. Next, what are the other things that you should know? One is infusion of oxytocin in labor, during labor, is titrated according to fetal monitoring that is done, which we'll be discussing in OBG. Second is we'll have to monitor uterine tone also postally. That is for PPH. Basically, if there is a decreased tone, then we have atonic uterus. Okay, so in that case, we'll have to increase oxytocin. So we'll be giving oxytocin, which is a uterotonic. That is, it increases uterine tone. Okay. Next, third is a nasal form of oxytocin is also available, which is used in case of lactation failure. Okay. So this is one thing you should remember. So don't confuse this with the desmopressin. Okay. Desmopressin is different and oxytocin is different. Okay, next, this I have already discussed, that it stimulates ADH receptors causing water retention in overdose. Second is oxytocin is destroyed in the gut, so not orally active, but we have now demoxytocin, which can be taken via buccal route. Okay. Next, I think I have explained all this. I don't have to go again. And yes, carbetocin means long. Okay, so this is how you remember. Carries better for longer. Okay, next, we'll go through the questions now quickly. So, important thing to remember here is IP3-DHG pathway, and second is the analogs of oxytocin. So which is the longest acting? Yes, very good. It is carbetocin. Next, stimulates DASH receptors causing water retention. It can stimulate ADH receptors or vasopressin receptors, which causes water retention. Third is contraindicated in what? Contraindicated in cephalopelvic disproportion. Next, drug of choice for induction of labor is? Yes, very good. Drug of choice is oxytocin. This is a drug of choice. Use DASH form for lactation failure. We'll use nasal route. Nasal form of oxytocin for lactation failure. Okay. Yes. We'll go on to the next topic, that is OCPs. Here we have some topics which are which are overlapping with OBG also, but anyways we'll be completing in both of them. Okay. So to know how OCPs act, we should know what is the hypothalamus hypopituitary gonadal axis, okay, HPO axis. So basically what happens is from pituitary gonadotropin releasing hormone, from hypothalamus gonadotropin releasing hormone GnRH is released, which leads to release of LH and FSH, okay. LH and FSH acts on the ovaries and then causes the effects. Now what happens is when you give OCPs, that is estrogen and progesterone from outside, that is from external administration, so this will block LH and FSH, okay. So there will be negative feedback and it will block. So estrogen plus progesterone, it will cause the effect whatever the hormones had desired to do, but at the same time it will cause negative feedback and decrease LH FSH levels and decrease GnRH levels. So basically LH is required for ovulation, okay. Because there is negative feedback of increased progesterone and estrogen from external administration. So that's why there is negative feedback and there is no release of LH, as a result of which ovulation doesn't take place. Okay. So that is the effect of birth control pills, that is OCPs. Okay. So there is no ovulation because we don't have that LH surge that occurs. So this OCPs can be combined, which has both estrogen and progesterone component, or it can be mini pill where there is only progesterone. So there are two types of dosing. One is constant dosing where daily will be having dosing, and second is biphasic and triphasic, that is varying dose. I'll tell you what it is. Okay, so monophasic means same dose of estrogen and same dose of progesterone is given throughout the cycle. Okay, so it is like 21 plus 7, whatever you have studied so far in your MBBS days, that is monophasic. Now what is biphasic? Biphasic means estrogen dose is the same, progesterone dose will be gradually increased in the mid of the cycle. So you see these yellow pills, these are increased because level of progesterone is also increased during that phase. If you see estrogen progesterone levels, that also progesterone increases during mid phase of the cycle. That's why we increase dose of progesterone during that cycle only. And triphasic means initial progesterone will be low and later on it will go on increasing. So this is more like a physiological how it is, okay, how physiological response will be. So it will mimic, triphasic will mimic closely, okay. So basically in monophasic we have constant dose, and biphasic dose will vary according to whatever is set, okay. Here only in the mid phase it will increase, and here gradually it will increase till the end, okay. So these are the three types of formulations we have in OCP. Now what are the benefits of OCP? OCP benefits are, one is it promotes, what happens in OCP, there is no only estrogen action, there is estrogen plus progesterone action. So progesterone action prevents like excess estrogen action, unopposed estrogen action, and this is useful to prevent malignancy like ovarian malignancy and endometrial malignancy, where it occurs because of excessive progesterone, excessive action of estrogen, okay. And it also decreases anemia, it regulates menses. So basically those who have like irregular cycles, okay, it will regularize the cycle because we are externally administering the hormones. Now what will happen in case of failure? So there can be two reasons for failure. One is missed pills. Second is, I told you in the initial part in pharmacokinetics, there are some enzyme inducers, okay. So let's say some enzyme inducers like anti-epileptics or antibiotics, which can induce the enzymes and it can cause breakdown of OC pills quickly, okay, or these enzymes. So in that case, there can be failure of this OCPs. So this will be asked in your questions. Next, what are the risk factors? So if patient is smoker and more than 35 years, then there is risk of thromboembolism along with OCP, because OCPs promote actually thrombosis to some extent. And breast cancer and liver diseases, it is contraindicated because you know that in breast cancer there are progesterone receptor positive breast carcinomas, okay. So that's why if you give progesterone along with that, it can cause unopposed action and it can actually worsen malignancy, okay. So in case of breast cancer and liver disease, we don't give OCPs. Next, what is levonorgestrel? Levonorgestrel is the emergency contraceptive which can be taken within 72 hours. Other MTP drugs are mifepristone and misoprostol. Okay, they are also. So mifepristone is a progesterone receptor blocker. Okay, it blocks progesterone, and misoprostol actually increases PGE1. Okay, so it causes myometrial contraction, which causes cervical ripening and then expels uterine content. So this is basically used for termination of pregnancy. Next, drospirenone. Drospirenone, does the name sound similar? Yes. We had spironolactone, we had eplerenone. Similarly, we have drospirenone, which is an anti-mineralocorticoid, okay, basically anti-glucocorticoid, along with anti-androgenic property. Okay, this is used for. So since it has anti-androgenic activity also, it is used in case of PCOS, okay? Because in PCOS we have increased androgens, okay? And at the same time we have irregular cycles also. So drospirenone has both anti-androgenic activity, it has anti-mineralocorticoid activity also. So it can be used for this PCOS, and in some cases for acne, and in some cases for premenstrual syndrome also. Now, what happens, there are some unique situations which can be asked in your exams. One is what happens if there is missed dose, okay? So if the missed dose is less than 12 hours, then you will take it immediately. If it is less than 12 hours, you will take it immediately and you will continue with normal the dose of the pills, okay? There shouldn't be any changes. Now, if it is less than 24 hours also, the same thing will be done. That is, we will continue whatever the pill was missed, and then suppose the difference is less, then also we'll take it. Okay, there won't be any issue. But if it is 48 hours, no, then what will happen is, if it's more than 48 hours, okay, let's say like patient took on day 1, 2, 3, and on 4th day also patient missed, 5th day also the patient missed. So what will the patient do? On 6th day, the patient will take the missed pill, okay, the most recently missed, that is 5th pill the patient will take, and on the 6th day whatever is there, that also patient will take, and it will continue, okay? So whatever was there on 4th day, patient won't take, okay? This is in case pill more than 2 pills are missed. Okay, so it must be very clear to you. Okay, so that is, let's say, I'll again give an example. Okay, so this is Sunday, Monday, Tuesday, Wednesday. Okay, so suppose patient takes on Sunday at night, let's say 10 p.m. the patient takes the pill. Okay, Sunday, Monday the patient took, but on Tuesday the patient forgot, and Wednesday patient at 10 a.m. remember that has not taken prior pill. Okay, so in that case what will happen is patient will take Tuesday's pill at 10 a.m. Okay, and then that night, daily night 10 p.m. the patient takes, so that also pill the patient will take. Okay, so in the day she will take 2 pills, and then she will continue normal cycle. Okay, yeah. So this is like less than 48 hours have passed. So but let's say patient didn't take on Tuesday, didn't take on Wednesday also, and Thursday at 10 a.m. the patient remembered. Then in this case, more than 48 hours have been passed. No? So in this case, what will be done is, Wednesday's pill will be taken at 10 a.m. Thursday's pill will be taken at 10 p.m. at night as usual, and then the things will continue. Tuesday's pill was there, no? That will be discarded. Okay, so there shouldn't be any confusion regarding this. Now, whether emergency contraception is required or whether backup is required, so that will depend on which week this has occurred. Okay, so suppose it has occurred in the week 1 of like OCP, in the week 1 the pill has missed, then there is higher risk of chances of pregnancy. So in that case, if unprotected intercourse occurs in the last 5 days before the pills are missed, then emergency contraception is required using levonorgestrel. If it is in week 2 and if more than 48 hours have passed, all these week 1, week 2, week 3 which I am telling is for more than 48 hours. Okay, less than 48 hours there is less risk because ovulation would be suppressed by then. Okay, so if it is more than 48 hours and if it is in the first week and intercourse has happened in the last 5 days, then emergency contraception is required. Okay, if it is in the second week and more than 48 hours have passed without pill, then you will have to give a backup contraception. Okay, backup contraception for 7 days. Emergency contraception is not required. Now in third week, so just take the recent pill and use backup for 7 days. Okay, backup for 7 days. There is again no need of emergency contraception. Okay, so I don't think they'll ask this one. It is not above your level for NEET PG. This is a question for NEET SS in OBG. But anyways, you should know basic thing that less than 48 hour rule and more than 48 hour rule you should know. So if any dose is missed less than 12 hours, then definitely it should be taken immediately, followed by that day's pill. Okay, next. Start day of the OCPs is from start days day 1 to day 5 of menses. Okay, all these things are regarding OCP because OCPs cause weight gain. Okay, it can cause hypertension and you'll have to exclude pregnancy before that. So all these things you can go through. Okay, I think I have explained everything in this. Okay, so we'll go to the questions now. Okay, so failures, missed pills and antibiotic use. This is because of decreased what? Yes, it is because of decreased enterohepatic circulation. It is because of decreased enterohepatic circulation. Okay, next. Dash emergency pill should be taken within 72 hours. Levonorgestrel. Dash has anti-androgenic and anti-mineralocorticoid activity. Yes, very good. Risperidone. Next, mechanism of contraception is, what is the mechanism? Yes, it is inhibition of LH surge. LH surge won't happen, so it will inhibit ovulation. Okay, so we'll go to the next topic, that is GnRH agonist and antagonist. Again, relatively confusing topic only. Okay, so we don't have many questions from this, but we are not going to leave any chances also. So basically what happens is, again we'll go to pituitary. So GnRH receptor is present on the pituitary. Okay, so this agonist, what will it do is, what will happen is, there is pulsatile release of GnRH, that you should know. In physiological doses, GnRH is not released continuously, it is released in pulsatile manner. Okay, so if there is continuous stimulation of this GnRH receptor by this agonist, what will happen is, it will cause increase in LH-FSH, it will cause increase in the sex hormones, it will also cause receptor down regulation. Okay, that is LH-FSH receptor down regulation, and it will cause long-term block. So when this GnRH agonists are used on long term, it will cause the opposite effect. It doesn't cause stimulation, it will cause inhibition of that receptors. Okay, so it causes something known as receptor desensitization. Whereas on the other hand, antagonists, they are used for immediate block. Okay, so let's say this is GnRH receptor and this is GnRH receptor antagonist. There will be immediate block and LHS and FSH release is prevented. Okay, so this is how it is. Agonist will stimulate and it will cause delayed block, but antagonist will cause immediate block. Okay, so continuous use causes inhibition, pulsatile uses causes stimulation. Okay, so this is what happens in physiology. Okay, physiology of this. So which are the GnRH agonists? Yes, they are leuprolide. So basically you should have this yes, RE. Okay, there are RE in both. Okay, so how we'll remember is leuprolide, PR. Okay, PR, leuprolide, goserelin and nafarelin, these are agonists. Antagonists are cetrorelix, ganirelix, degarelix. So this, you will have to remember just this leuprolide. Okay, it is being asked many times. So you'll give continuous infusion of this agonist, which will cause receptor down regulation and it will cause block. Okay, next, pulsatile, if it is there. Okay, so what we do in infertility therapy is where we want increased GnRH. Okay, if there is increased GnRH, then there will be increased LH and increased FSH. Okay, this is what we want in infertility. So what happens is, we want to stimulate production of GnRH. So that will be, we'll have to mimic GnRH. So we'll have to give it on pulsatile basis. We don't give it in continuous basis. Continuous we want when we want to decrease LH and we want to decrease FSH. So this is very important concept which students often misinterpret. They'll think that agonist means it will stimulate, antagonist means it will inhibit. Here it is not that. In agonist only, you will have two type of action. One is, if it is continuous inhibition, it will cause inhibition of LH and FSH. If it is pulsatile stimulation, then it will cause increased LH and FSH, which is used for infertility. And continuous is used for prostate carcinoma and endometriosis. These two conditions will use. Okay, so pulsatile versus continuous, again you shouldn't confuse it. Okay, now flare must be covered with anti-androgen. What does this mean? Okay, the meaning is simple. See, I told you, whenever there is continuous infusion, what will happen? Whenever there is continuous infusion, okay, whenever there is continuous infusion, the levels of LH and FSH will rise. Okay, now along with that, what will happen is there is a problem, that is, it will increase testosterone also. Okay, testosterone will also increase because increased GnRH causes increased LH and increased LH causes increased testosterone. So this is in the initial week. Okay, so increased testosterone is very bad for prostate cancer because that is the reason basically prostate cancer has occurred. Okay, so that's why in the initial few days when we start leuprolide, we'll have to give anti-androgen so that there won't be increase in testosterone. Okay, that is the meaning of this. Next, prolonged hypoestrogenism osteoporosis risk also occurs because when we are giving prolonged GnRH agonist, FSH will decrease. FSH decrease causes decreased estrogen. So as a result of which there is risk of osteoporosis. Okay, next, GnRH antagonists avoid flare in prostate cancer. Yes, the meaning of this is that I told you there are two type of drugs. One is GnRH agonist and second is GnRH antagonist. Okay, so agonist, what it will do? It can have pulsatile action also. It can have continuous action also. Initially, its action will be pulsatile, which causes mild increase in GnRH initially. When you give for long term, it will cause inhibition of GnRH secretion. So it will cause decreased LH and FSH. This is long term effect. But short term, what will happen? It will cause increased GnRH, it will increase testosterone. So in case of prostate cancer, we'll have to give anti-androgens, that is androgen blockers. Example is bicalutamide. Okay, bicalutamide is most commonly what we use. Okay, bicalutamide. Now this problem doesn't occur with antagonists because antagonists cause immediate block, right? So that is the meaning of this. GnRH antagonists avoid flare, so it can be used in prostate carcinoma. Okay. Next, nasal nafarelin. Okay, nafarelin, I told you, goserelin, nafarelin, and luprolide. These three are GnRH agonists. Okay. So this is used in endometriosis. So this nafarelin, what it does is it will decrease FSH, it will decrease estrogen. So that's why we'll have some symptom improvement using nasal nafarelin. Okay. Now again same thing, combine with androgens initially if it is GnRH agonist. Add on progesterone and estrogen for endometriosis, that is OCPs. I told you OCP is preventive. And third is reversible suppression upon discontinuation. Leave that thing. Okay, it is not required for you. Okay, I think I have explained everything in this. I know hormones are a bit difficult endocrine because you'll have concepts also. You need understanding. See, unless I told you what is GnRH agonist and antagonist, how their mechanism of action is exactly, you wouldn't have understood. Okay, that's why it took some time. Agonist, which the prototype drug is, yes, luprolide. Okay. Next, nasal nafarelin is used for which condition? Endometriosis. See, since you have seen image now, you are not going to forget these things. Drug avoiding flare is, yes, it is anti-androgen bicalumetide. Okay, that is anti-androgen if you want. And if you want GnRH antagonist, we can give directly GnRH antagonist, that will avoid flare. Pulsatile agonist is used in infertility, okay, because we want to increase GnRH in that case. Okay. Next, we'll go to drugs causing hyperprolactinemia. Okay, now continuing with the next drug, that is drugs causing hyperprolactinemia. This mechanism I had once explained in pathology also. I'll just make it a brief summary here. So basically, there is something known as tubuloinfundibular pathway. Okay, so this tubuloinfundibular pathway maintains the secretion of prolactin. So prolactin, you know, is secreted by anterior pituitary. This prolactin is under inhibitory control of dopamine. So dopamine inhibits release of prolactin. Okay, so as simple as that. So any drug which blocks dopamine, now what it will cause? It will cause prolactinemia. As simple as that. Okay, so you don't have to go any further in this. So your question will be galacturia, that is increased milk secretion. Okay, that is milk secretion, along with amenorrhea, because prolactin causes amenorrhea. Okay, so increased prolactin causes amenorrhea, along with D2 blockade, that is dopamine receptor blockade. For example, extrapyramidal symptoms, tremors. Okay, all these three will be symptom characteristics of dopamine inhibitors. Okay, so what are there? Galacturia, amenorrhea, and D2 blockade. So which are the drugs which cause D2 blockade and cause hyperprolactinemia? One is antipsychotics. Most of the antipsychotics, they cause blockage in this tubuloinfundibular pathway between hypothalamus and the pituitary. So this D2 blockade causes hyperprolactinemia. Second is antiemetics like metoclopramide and domperidone. In few slides before, I had also talked about metoclopramide. There also we had seen that it had D2 receptor antagonism. So it is an antiemetic that also causes hyperprolactinemia. Third is antidepressants. Okay, they increase serotonin and they decrease dopamine tone. So they also cause hyperprolactinemia. Next is antihypertensives, which are less frequently. And then there are like estrogens, which directly stimulate prolactin secretion. Okay. Out of all these, I want you to remember two important drugs, that is antipsychotics and antiemetics. Along with that, remember antidepressants also. Now, pituitary prolactinoma is, now this drugs causing hyperprolactinemia should not be confused with the pituitary prolactinoma. Okay, there the problem is with pituitary tumor. Okay, there it is not with dopamine inhibition. There actually prolactin is secreted more by this pituitary cells. So don't confuse this hyperprolactinemia with drugs causing. Okay. Next, second is risperidone among antipsychotics. Okay, this risperidone is there. It is the most potent. Okay, so in the question, if risperidone is there, that is your answer. Next, abrupt withdrawal may worsen psychiatric symptoms, because thinking that okay, Next, rare facts are like clozapine and quetiapine. These two are atypical antipsychotics, but their chances of causing hyperprolactinemia is actually low. Okay, so we are mainly considering about risperidone. Just remember risperidone, that is enough. Next, domperidone acts peripherally and it has less CNS effects. So extrapyramidal symptoms are also less in case of domperidone. Next, methyl dopa, which induced galactorrhea reversible on discontinuation. Okay, so once you discontinue methyl dopa, that induced galactorrhea will stop on its own. Okay, so I think I have, so basically whenever you have a question on galactorrhea, amenorrhea, so next you will review whatever the drugs that are given for the patient. In that you will find D2 blockers. Next you'll measure prolactin level and you'll see if there's a drug causing galactorrhea, especially risperidone. And other drugs are antiemetic causing hyperprolactinemia, metoclopramide and domperidone. Okay. So there is one more inverse relationship of serotonin and dopamine. Whenever serotonin is high, that time dopamine will be low, and when dopamine is high, serotonin will be low. That is the mechanism behind this antidepressants causing SSRIs causing D2 blockade. Okay, let's go through the questions quickly. So drugs causing hyperprolactinemia, antiemetic. Which antiemetic causes? Metoclopramide. Next, dash antipsychotics least likely. Clozapine and quetiapine, they are atypical antipsychotics. They are least likely to cause increased prolactin. We have typical antipsychotics which causes increased prolactin release. Drug causing galactorrhea, yes, it is risperidone. If one option is given, it is risperidone. Antiemetic causing is domperidone. And one more is metoclopramide. Metoclopramide has more effect than domperidone. Okay, yes.